Good
Okay.
afternoon, everyone. Thank you for joining us. Well, good
Thank
afternoon,
you very
good
much.
morning, good evening, depending on which part of the world you're at.
No, thank you very much.
Okay, that's fine.
This is series 3 of a series of meetings we're having, cross-specialty research meetings, along the themes of focusing on issues of certain vulnerable groups, an often neglected but important part of society. And this has come to the forefront, and all our weaknesses show up based on how we respond in the presence of a major pandemic like the COVID-19 pandemic. So we are honored to have you from the Urology Innovation Center at East Kent Hospitals University NHS Foundation Trust. We have an incredible faculty. What I will do is introduce our chief exec, who will say a few words, and then I will introduce you to our chairman, who will then take over as the chairman for this session, entitled Evolving Trends in Vulnerabilities and Unequal Impact in COVID-19. So thank you for joining us. Susan, you want to say a few words?
Thanks, Sashi. It's nice to see you all again, and nice to be involved in this faculty. I think it's really fabulous in terms of the work that you're doing to promote this area, and I also find it very interesting as well. So I'd like to thank everybody for joining this meeting again. It's a very academic and amazing group of people that have been assembled to give this topic the right kind of priority and airing that it needs. So thank you very much, Sashi and Mo, for arranging and organising this, and also really providing the continuity and the energy around it as well. So I'm looking forward to it, Sashi. So back to you.
Thank you for joining us, Susan, despite your busy schedule. I know this has been an incredibly busy week for you. Without further ado, I wanted to introduce a colleague who I have great respect for, Dr. Mohamed Sakel. This is a gentleman who I was really inspired by as a senior colleague. As a surgeon, one would wonder why I have a relationship with a medical doctor, but he's incredible in his forward thinking. He is the sole consultant director for a service led for neuro rehabilitation in East Kent. He was appointed in 2003. Forgive me. And founded this service for 18 years. This specialist service provides consultant-led specialist multidisciplinary team clinical for a 19-bedded inpatient unit supporting complex neurological cases, including traumatic brain injury, complex stroke, COVID-19 survivors, and other complex neurological conditions. Outpatient clinics for spastic treatment are also provided by Dr. Sakel's team. This is a unique specialist cross-specialty research team that we have founded. He created and leads this team. This is a unique multidisciplinary research team, which is actively researching BAME vulnerability to COVID-19, but we have now expanded that to include all forms of vulnerable people. COVID-19, he is also now leading an international research project exploring COVID-19 survivorship, which aims to describe persistent symptoms or long COVID experienced by spinal cord injury survivors in Bangladesh. This is the third live research webinar supported by Dr. Sakel's team and is an inclusive event open to all sharing and learning. Dr. Sakel has created and leads the Kent Brain Injury Care Global Collaborative Network Group and is considered a key opinion leader in botulinum toxin, spasticity, and robotics. He has over 50 publications focused on improving neuro rehab care. So it's an honor to hand you over to the chairman, Dr. Mohamed Sakel. Thank you.
Thanks for your kind words, Sashi. So we are waiting for our Honorable MP, Rosie Duffield, to join. And so before I say anything, I would like to say special thanks to Andrea Ashman, who is here. Andrea, if you want to say something before we start.
Thank you. I'm just delighted that you've invited me to join you today. I think this is such an important area of work that you're doing, and I feel that I've managed to develop some personal relationships with many of you over the last few years, and particularly through COVID. And actually, you know, just encountering you on the wards and the work that people are doing, it just reinforces the importance of what you are doing, but actually what we are doing as a team. So thank you very much, and I'm just delighted that so many people are here this evening.
Thanks for your kind words. Right, so we'll be waiting for our MP, Rosie Duffield, to join. She will be joining in from House of Commons, if she could navigate the WebEx IT system. Otherwise, we'll just carry on.
I think,
So,
Mo, I think she has joined.
oh, she has joined.
Sorry for being late. I finally worked out what I'm doing, I think. So hopefully it'll work.
Yeah, it is working. Yeah, thanks.
Yes,
Thanks
it
for
seems-
joining in. Yeah.
Thank you for inviting
If you could say a few words, please.
Sure.
We start.
Okay, I'm only going to speak for a very short time, but it's a real honour to be invited here to speak in today's event. And we're focusing on the unequal and disproportionate impacts of COVID-19 on vulnerable groups. And it's a real honour to be hearing the research and evidence put together by our own experts here in Canterbury from UKC and our hospital and EMIC as well, among others. Of course, we know that such catastrophic events such as pandemics and climate disasters cannot necessarily be prevented or planned for, but we do know that those most vulnerable already are absolutely bound to be the very worst affected. If you add poverty, malnutrition, lack of adequate housing, job insecurity to an aggressive illness, then it doesn't take a brain surgeon or an eminent urologist to tell us who in the world will have the worst outcomes and who will suffer the worst, and which groups are most likely to suffer the highest number of deaths as well. My colleague Marsha de Cordova, Labour's Shadow Women and Equality Secretary, led a debate in Parliament earlier this week on the impact of COVID on certain vulnerable groups. And all we want really is for the government to collect data. We know it's an issue that needs serious investigation. We know that 94% of the doctors that have died have been from a BME background. Difficult. We need the data collected. We need to know exactly what we have happening again. And we need to know how to tackle those inequalities that have led to people being so vulnerable in the first place. Another issue that I've been talking to Mr. Shrotley about is, although the majority of the workforce in the NHS are from a BME background, a lot of whom are women, the people at the top and making the decisions often are all pretty white, to be honest. And I think we absolutely have that, and to see why that's happening, why people in management do not reflect the workforce in the way that they should. I think that that's something that may come out from this discussion as well. I'm going to be really interested in hearing the data that you've collected and having that as a tool to present to Parliament when I'm arguing that we need to do more about these issues. The more data we can have, the more proof people like me have got when we bang on about this ad infinitum, which is one of the things. So thank you very much for coming together, for bringing us all together, people from around the world, to discuss this.
Thank you for taking your time. We have a stellar lineup today. I'll just say, if I could request everyone to unmute, to mute, please. If I could request everyone to mute, please.
You have the control, so you just mute the room.
Can't believe someone is doing that. Okay, I think we'll back. Right. Actually, what connects Shashi and me are actually robots. I do robotic research for multiple sclerosis and spinal cord injury, and Mr. Sashi actually used robot for his prostate operations. I talk about how to adopt or diffuse innovation. Mr. Sashi actually built an innovation center. So I thought it's better that I got alliance with him. So when the COVID started, we created
into a voluntary phone and service radio specialist service provider.
Oh dear. I will get hold of it soon. Okay, we created this a cross-specialty research team, which is from multiple institutions. So we have a multi-organization and multidisciplinary. So we have Mr. Sashi, a surgeon from our hospital, a professor from KMPT, neighboring hospital, Mr. Shakti, who is a retired consultant and BMA late, Karen Saunders, a PhD research fellow, physiotherapist, and we have a national lead of physiotherapist from Bangladesh. We started various kinds of research, which we are sharing with different countries, with Bangladesh, India, UK, and US. And in this program, there will be speaker and observer from United States as well. So if I could introduce one by one, Mr. Nitin Shatri, I think most of the doctors in England will know, consultant urologist. And our Honorable MP, Rosie Duffield, who has just spoken. And it's a great honor to have Professor Anton Emmanuel, who is the national lead for workforce race equality standards, strategic lead. We had Professor Laurie Walton from Scranton, the same place where Mr. Joe Biden is from. So thanks, Laurie, for joining in from US. We have our BMA chairman, Dr. Nagpaul, kindly joining us, and he will be delivering the keynote speech. Karen Saunders will be presenting the multi-institutional research on knowledge, attitude, and practice of BAME in relation to COVID, and also one of the lead for long COVID in spinal cord injury patients who have got COVID. Mr. Aftab is an ophthalmic surgeon from Northern England. He has done actual research on unconscious bias, and he will be sharing with us the data. We have my friend Professor Dawn from Indiana, who will be observing today and will be in the panel, and he will speak in the summer event. It's an absolute honor to have Professor Mala Rao, who is a strategic lead for RES, who will be delivering another keynote speech. And our chairman from Ethnic Minority Independent Council, Reverend Mike, unfortunately is quite unwell. So he won't be able to join, but in his place, Natalie will be talking with us. Right. Request is I need to stop sharing, and I will request our first speaker, Dr. Nagpaul, to kindly. Do you want me to share your slides, or will you be able to share your slides?
I'll try and share them myself.
Oh, fair enough. So shall I introduce Dr. Nagpaul, because some of the audiences are from United States and India and Bangladesh, so they may not know you. Our CEO, Susan and Andrew Ashman is here. Right, so Chaand Nagpaul, CBE, FRCP, GP, has worked as a GP in his group practice for over 30 years, serving a large multi-ethnic community. He's the first BAME chair. BAME, for my US colleagues, stands for Black and Asian Minority Ethnics. Chair of the British Medical Association Council, representing the medical profession across the UK to government and policymakers. As AMA Council Chair, he has championed race equality in the NHS. He has been a visible figure calling for action to address the disproportionate impact of COVID-19 on BAME healthcare workers, the communities, and gave evidence on this issue to parliamentary committees and contributed to Baroness Lawrence review on avoidable crisis. Dr. Nagpaul is listed in Health Service Journal's 50 most influential BAME people in health 2020. Dr. Nagpaul is a past chair of the BMA GPs committee and a fellow of the Royal College of General Practitioners. He was awarded a CBE in 2015 in recognition of his service to primary care. Dr. Nagpaul, if I could apologize and say I actually forgot to introduce Professor Mala Rao Walton. She will be speaking on another vulnerable group, which is domestic abuse within the COVID pandemic, and that will lead to our next talk in summer about another vulnerable group of LGBT. Right. So the mic stage is for Nagpaul. I'll try to
Oh, do you have the mute function on you?
I have mute all now. And I'll try to unmute just, yeah. So Dr. Nagpaul, you can unmute yourself now.
Right. Okay, should I start?
Yes, please.
So first of all, can you see and hear me?
Yes.
Okay, good.
Yes.
I just want to first say I'm really delighted to be part of this event, and I want to thank you, Mo, and all of you who've organised this event in bringing together so many esteemed colleagues in trying to understand and have research informing what we've witnessed in terms of the impact of COVID on Black ethnic minority populations. So thank you very much for a fantastic program. Now I'm going to share my screen. Let me just check that it works. Right, just 1 second.
Yeah, we can see your work.
Okay, I'm going to just make it a full screen. Can you see that? Can you all see that?
Yes, we can see.
Fantastic. Okay, so I'm going to be just talking about the experiences of BAME doctors in the NHS, both before the pandemic and during the pandemic, from our position as a BMA representing doctors across the UK, and we're in a good, strong position to really understand the day-to-day realities of the members we represent. So whilst today's meeting is very much about COVID and the experience of, and I'm going to be focusing on the experience of doctors, not communities, doctors that I represent, I think it's worth reminding ourselves that we have had a very unequal NHS that has disadvantaged BAME healthcare workers well before COVID hit our shores. So one of the first things I did when I was when I became chair of the BMA Council is I led a project really looking at culture in the NHS and other aspects of the NHS, and it resulted in a very large piece of project work, surveys of the profession, and I want to just run through the experience of BAME doctors before COVID. So in 2018, this was probably one of our largest surveys we have ever did, the most comprehensive. We knew at that stage that BAME doctors were telling us that they were living in a climate where they felt that they were being blamed for medical error that was not in their control at a much higher rate than their white colleagues. Even worse, they said they didn't feel confident to raise concerns about patient care, and they also experienced bullying and harassment at twice the rate of their white colleagues. So as I said, this is well before COVID. They also felt that they were not experiencing, they didn't have an experience of being included compared to their white colleagues. They didn't feel they were part of teams. And if you put that all together, that's not a culture that's very helpful for one's mental well-being, you know. And as a result, we also do know from the GMC's own commissioned work that if you do not have well-being, if you're under mental stress, it impacts on your clinical performance. It means that you're more likely to make a mistake. A very good piece of work by Civility Saves Lives. That's an initiative which has shown that when you're bullied, when you're harassed, when you're really affected by negative experiences, it can actually reduce your cognitive experience by up to 61%. So I think it's just important to remember that reality before COVID became a reality last year. And we know that BAME doctors have for decades now had unequal experience in terms of referral for disciplinary processes, twice the rate of their white colleagues. And if you then look at those other stats that I showed you around feeling afraid to speak out, feeling that if you spoke out, you'd be blamed, you can see why you have a situation where many ethnic minority doctors haven't felt confident to stand up for themselves and have actually therefore suffered unequal processes, disciplinary processes. We know that differential attainment is a very sad reflection of our health service, where BAME doctors pass postgraduate exams at a lower rate than their white colleagues. Their career progression is therefore affected. And when independent researchers looked into this, Catherine Wolfe at UCL has done a lot of work on differential attainment. It is not because of any difference in ability. And I can tell you that as a BAME doctor, if I look at my medical school, there was absolutely no, and we know that doctors from ethnic minority backgrounds are not lacking in hard work. They're not lacking in ability, but the system they work in within the NHS does not allow them to flourish. It doesn't allow them to be supported to be their best. We know that, as I said, career progression is affected, and the Royal College of Physicians has shown that you're far less likely to be shortlisted for a consultant post, far less likely to be offered that job if you are from a ethnic minority background. As a result, you have far greater numbers of doctors who work in staff and associate specialist grades, and that again has resulted in an ethnicity pay gap in our health service. Now, when we therefore had COVID hit our shores last year, the first thing, of course, that we needed to do, and what I needed to do in terms of chairing the BMA, was to ensure that doctors were protected in an environment of a highly transmissible, highly deadly virus. And we actually increased our helpline. We have a member support line, which, like most support lines, operate midweek, and we did them on Saturday as well. We made it 24 hours a day, 7 days a week, because we knew that members would be worried, they'd be anxious about being exposed to this virus without sometimes protection. And we carried out about 11 tracker surveys throughout April to the current day. So we've actually amassed a huge amount of information about the experience of doctors on the front line throughout the pandemic, with sort of responses of up to 16,000 doctors replying to our surveys within 48 hours. So I think we're very well placed to and that's what I'd like to share with you. And throughout the pandemic, BAME doctors experienced greater hurdles and a more negative experience. And in fact, in the height of the first peak, back in March, April, when you will remember, we had extreme shortages of PP running out in many units, and we had to get emergency supplies from other countries. At that point, BAME doctors were telling us they were 2.5 times as likely to feel not protected at work compared to their white colleagues. And they were twice as likely to tell us they felt pressured to see patients without the right protection compared to their white colleagues. And even now, more recently in December, we still have twice as many BAME doctors saying they do not feel protected compared to their white colleagues. And also when you look at the use of fit testing, higher numbers of BAME doctors tell us that they are concerned that they have not passed fit tests, but still feel pressured to carry on seeing patients without that proper protection. Now, the culture I mentioned prior to COVID just got worse during COVID. So we actually had doctors telling us, again in our surveys, many more BAME doctors telling us that they did not speak out when they didn't have sufficient PPE. And they didn't speak out because they were afraid. 2.5 times as many BAME doctors said they were afraid of the consequences of speaking out. And then when we asked them, why are you afraid? They said they were afraid of issues such as recrimination and a lack of career progression, thinking that if they challenged, it would have a negative impact on them. And actually bullying and harassment, which I said earlier, has plagued our health service for far too long, got worse for BAME doctors in the last year. And they felt bullied and harassed, not just by managers, but also by their own colleagues. And all this, I think, is typified in a tragic case of a doctor, Dr. Peter Tun, as one example of countless doctors who was a prominent local BMA member. And basically last March, he complained. He was working in a neurological rehab associate, as it happens, at Royal Berkshire Hospital, and he was very concerned about lack of PPE. Now, the doctors here will remember, the healthcare professionals here will remember, last March, the PPE, the PHE guidance on PPE was not to wear masks and goggles in non-COVID areas. That is what the guidance was last March, early March. And he was working in a non-COVID ward, and quite rightly did not feel protected and was concerned that patients on his ward could be infected and in turn infect himself and other doctors. He pleaded for PPE and his trust management rejected his request. So he carried on working without PPE. 4 patients on that ward about 4 days later contracted COVID. They must have caught it in hospital. About a week later, Dr. Tun was seriously ill, positive himself. He went onto a ventilator. 3 weeks later, he died. Now, one of the most upsetting experiences I had last year was speaking to his son, who showed me emails between himself and the management of his hospital. And it was very painful because he didn't feel able to challenge. He just took it as a rejection that you cannot have PPE, and he carried on working. His case has been well publicized in the media, so you can look it up. But I think this highlights what I mentioned earlier, a culture of feeling unable to speak out in terms of representing your own interests. So that was a tragic example of the culture I was talking about. Now, even now, ethnic minority doctors remain, they tell us in our surveys, they continue to feel insufficiently protected. So as you all know, we have risk assessments now that have existed since the end of last summer in all NHS providers. But actually, BAME doctors tell us that in addition to the risk assessment, they don't feel that the necessary adjustments have been made to protect them. Twice as likely to feel unsatisfied. They've also been more likely to say that their risk assessments have not been updated in a way that they should be, because these should be dynamic processes. So again, it isn't that things are okay and the risk assessment, isn't an endpoint. It's what you do after the risk assessment with a mutual agreement with the healthcare professional that really counts. In terms of doctors' well-being, what our surveys have shown again is that doctors from an ethnic minority background have had a worse experience. During the first peak, they said they were more likely to not be allowed to take breaks that they asked for, twice as likely to have to cancel leave compared to their white counterparts. They're more likely to report stress and burnout, and they also had some difficulty accessing well-being support. All of this, as I said, is not new. It just became more visible during the pandemic, and this is exactly what our surveys have shown. From our end at the British Medical Association, I can at least say that we have spoken out from the beginning about these issues. So in early April, when the first 10 doctors who died were all from an ethnic minority background. I mean, that was just a shocking statistic. I mean, it just goes beyond any statistical explanation. And we spoke out, and I was interviewed in The Guardian, and we called it out, and we called upon the government to take action and do a review and inquiry. And about a week later, the government did announce a review that was then commissioned from Public Health England. And we've certainly been raising these issues from politicians from both sides, both main political parties. I've certainly given evidence to many select committees on this issue. And so from the BMA's end, I can say that we have shouted alongside many other organizations. Many other organizations have also joined in this call for action. I think I wrote 3 letters to Simon Stevens back in April, because it wasn't a review that we wanted alone. We wanted protection, and we wanted doctors to be risk assessed and protected, and those that were at the highest risk should have been redeployed or done some remote work or been in non-COVID areas. That's what we called for. That's exactly what a risk assessment should have been. That's what a risk assessment involves. But it actually took until the end of May before NHS England put out a directive and told all providers that they had to risk assess doctors. So it did require a lot of pushing from us. At the BMA, we even took matters in our own hands. We've developed our own best practice risk assessment tool, which can be used by any provider and can be used by doctors themselves. I also want to, I think, highlight that what the pandemic has shown is just the invaluable contribution of our international medical graduates and overseas healthcare professionals. You know, we've all known that the NHS could not have actually been created, could not have survived, and would today collapse if it wasn't for the contribution of our overseas healthcare workforce. But the pandemic, I think, brought it really home just how much they have contributed, especially when you look at the faces of all those healthcare professionals who have died, the several hundred. In fact, the vast majority of them are healthcare professionals that traveled from all corners of the globe to save the lives of others in our NHS, but who ended up losing their own. So we campaigned alongside others to have indefinite leave to remain for the dependents of overseas healthcare workers. We wanted the illogical and insulting healthcare surcharge to be scrapped. I'm glad that was scrapped thereafter. And also visa extensions for many doctors stranded here who could not return back home, especially those sitting exams. We also, in the BMA, have taken this work stream extremely, you know, it is an important work stream to support our overseas doctors. We now have a international medical graduate work stream, and Nitin Chaudhry, who's featuring in today's meeting and helped organize today's meeting, plays a very important and prominent part as a council member leading this work stream. We have a newsletter, which is on the right-hand side of my slides, which I think we've sent out 3 newsletters to overseas doctors. What we at the BMA want to do is tell our overseas doctors that we are here to support you, because they really do deserve to be valued and recognized. And what we want to do is champion their cause and make sure that as an association, we can provide them with tailored support, because they do face additional hurdles. I mean, coming to another country is difficult enough for anyone, but even more difficult when you have to battle with all of those cultural inequalities that I described earlier. The other thing we've done at the BMA, and the pandemic has really, I think, brought to the fore, is the need in the BMA for us to support and give voice and give advocacy to our BAME members. So we've launched a national BAME forum, but it's actually underpinned by regional networks throughout the UK, where grassroots ethnic minority doctors can come together, have a voice, support each other, and actually influence the policy we at the centre develop on their behalf. So I'm very pleased that that is now a reality, and we hope that that will achieve change in the future. I also think it's important when we talk about BAME doctors and overseas doctors that we don't only focus on the need to address the inequalities. We should also use language about embracing and championing and celebrating the incredible talent, diverse knowledge and expertise they bring to our NHS. It isn't about just ending inequality. It's about positively seeing this as a good for the NHS. We are much richer for the diversity that our ethnic minorities bring to our health service. So what are we calling for? I mean, ultimately, this has to be about change. It has to be about action. And the pandemic, I believe, you know, it demands that something is done. And I believe this today's conference that you're holding is part of that momentum of calling out the problems we've had and a call to end this long-standing inequality within our health service. We have to move beyond rhetoric and reviews. And ultimately, the only way this will change is to address the structural root causes that have led to the problems we see. I focused on the medical profession, but those structural causes, and you'll be hearing from others speaking, apply just as much, if not greater, to the communities that we serve that also needs to be tackled. In terms of the NHS, the culture has to change. We need a transformative culture that ceases discrimination within our health service, that makes sure that everyone can feel confident to speak out, can actually be valued for being able to speak out and helping improve services and patient safety without any fears of recrimination. For our international medical graduates, our overseas healthcare workers, we have to have a much better induction process. We need to make people feel that we're welcoming them in our nation. And when they come here, we need to be thanking them for actually choosing to come to the UK, because they don't have to come to the UK and the NHS. They can go to other countries. And that will become even more important post-Brexit when we'll have a further pressure on our workforce. And remember that more than half of doctors who come who are registered with the GMC in any 1 year come from abroad. So if we actually start seeing doctors not coming to the NHS, it will have a catastrophic effect on our workforce itself. We need to actually get equality into the medical curricula and really into education at a very early stage, and not just talk about racial equality, but get imprinted into people's minds the benefits of embracing diversity as a good. But also we need accountability. And in our view, as a BMA, we believe that accountability needs to be also within leaders, within providers. That's not just medical leaders, but also managers. And that accountability ultimately has to be even above providers within integrated care systems of the future, within NHS England, and of course from ministers themselves. We need to have standardized monitoring of and reporting of racial disparities. You'll be hearing from Mala Rao later on, but we want to see data sets that can show us where the change is happening. Otherwise, we'll just be talking about it. So we need to have some hard evidence of change. And we also need evaluation of programs and policies and interventions. There are some good examples of providers that have achieved diversity and equality in their workplace. And what they found is that everyone's happier in those organizations. It's not just a case of removing a wrong for some who have experienced inequality. Everyone benefits. And in fact, we know that the outcomes for patients are better in providers that have greater equality and diversity. And we need to be using those examples to disseminate best practice and ensure we spread what actually works. So thank you very much for listening. And I'm looking forward to the rest of the evening, and I wish you a great conference. Thank you so much for allowing me to speak to you today.
Thank you, Dr. Nagpaul. If you could kindly give the presenting authority back to me, and I would request everyone to put their questions in the chat box, questions and comments, whilst you are thinking about your questions. I could read out some. There was a question from a Birmingham medical student to our MP, and that question was answered both by our CEO, Susan, and the MP. And there is a comment, a question from Andrea Ashman, our HR director, about our local data. Professor Anton Manuel actually will talk about national as well as our local data. And there is a comment from Professor Don Newman from Indiana, United States, that if I can read, yeah, it's a completely systemic issue. White people protecting positions of power need to identify effective methods to get more BAME people to be in positions of power. So whilst you were formulating your question, if I could make a few comments on Dr. Nagpaul's presentation. Thanks for reminding the tragic issue of Peter Toon. He was a personal friend of mine for the last 22 years. And I was forced to write a little obituary line for him. Yeah, and at that time, I could say, of course, your data shows that the NHS was very poor, but it showed another thing, which is variations. In March, my neuro rehab unit actually has had fully adequate PPE, and in March, we had all our staff and patients actual PCR antigen test, which amazed my colleagues in other parts of the country, that how come Eastern Neuro Rehab unit is having all this, but not the other units. So there is a variation. I'm not going to defend the NHS wrong data. I'm sure when Anton speaks, maybe other things will come out. So that's another point, and I just would like to say thanks for bringing this point, that it's now becoming very clear that we need to follow a little bit the Americans, where it's not just rhetoric. It's not just good enough to be not racist. We have to be anti-racist, and unconscious bias is becoming very clear, like more pronounced, and just like the Silicon Valley companies in America, probably we need to make unconscious bias as mandatory training. If there is any more questions, shall I unmute all? If I can find how to do that. No, I can't find unmute all.
So Mo, the person who wants to ask question can unmute themselves and just launch whatever they want.
All right, if anyone wish to or can do it. Or you can type your question in the chat box.
Hi, Susan.
Susan's got a question. Can I ask Dr. Chaand, what are the plans after COVID and we're in the sort of recovery phase? What are the plans by the BMA to look into the deaths of BME colleagues? Will there be a public inquiry? Will we have a sort of review of why these people were forced into positions of where they didn't have adequate PPE? Why did that happen? And it still has happened, and it has happened in the second surge as well. Will the BMA be taking this up soon?
Yeah, so I absolutely think that we, and the BMA supports a proper inquiry about all of the issues that have occurred during the pandemic. I mean, it's not just doctors, but it is also healthcare workers working in all settings, including care home staff as well. This does require a proper inquiry. I believe that some of the reasons that this has occurred, we know already, as I explained in my presentation. But what this does demand is that the factors that resulted in this must be addressed, and we must make sure that this is never repeated again. I just, it would be unforgivable to go into a future situation where these inequities that result in some healthcare professionals losing their lives should ever happen again. It's unacceptable. I would also think that the review must look at the community itself, because remember, many communities, not just healthcare professionals, have been hit very hard. Even now, if I'm not mistaken, about 28% of patients in intensive care units come from an ethnic minority background. That's twice the proportion in the general population. So the inquiry has to be both an issue of yes, accountability, but it must be for the purposes of not just learning lessons, but making sure that we take action to prevent these things happening again. But yes, we will be certainly working alongside others, and we're certainly calling for an inquiry, a public inquiry as well.
I think erroneously, Andrea, you have become the host now. If you can please let me reclaim my host.
Trying to give it back to you, Mo. It was certainly not my intention.
No, thank you. Right.
Susan had her hand up for something.
Yeah.
Yeah. Thanks, Sashi. Yes, Dr. Nagpaul, thank you for a very, very clear and interesting presentation. I guess as a chief executive of a very large hospital that hasn't got it all right yet, what would be the 3 things you would advise me to do? I'm not talking about COVID generally. I'm talking about the general issue around representation and influence of BAME staff and doctors in particular, perhaps.
It's the first is, and it's a difficult one to tackle because it's not a tick box, is really be committed to a cultural change within a working environment, realizing that in fact, first of all, healthcare staff are working in an impossible situation. We all are. I mean, you're trying to manage a budget that doesn't stretch to the all chief executives are. So in that environment, the culture needs to be supportive. There should be a concerted effort made to recognize that there are some groups of healthcare professionals that feel marginalized, they feel excluded, they feel they have negative experiences of bullying, harassment. That all results in them not being able to be their best. That's what the stats show. By being cognizant of that, I would want to suggest that there is a program of cultural change that addresses that. Just as we've been calling about culturally sensitive messaging for the community, I think we need culturally sensitive approaches for many of our healthcare staff, especially those that come from other countries. It is extremely daunting to come and work in the NHS when you've never been brought up in this culture. And that means much better induction, much better support, more leeway for people getting it wrong because they don't understand the system. So I think that's another approach. And the third is one of a culture of learning. You know, we've heard about this before, about a just culture, about realizing that things will sometimes not go right, but using the opportunity for staff who work in a hospital, in this case, to feel they are part of that change. They can speak out without fear, and the system learns and improves. So I would put those together, but it is therefore under the heading of culture, positive culture.
Thanks, and I've got my host status back. Right, there are some excellent comments in the chat box you can read. Those, Professor Dawn Newman used to say something. You need to unmute.
Yeah, I wanted to jump in, and this is a really important question, I think, about what could be done from a CEO level. And I also just want to thank you so much for that presentation. It was really phenomenal, hit a lot of marks. So in Indiana, so obviously there's lots of concerns everywhere. And I think this has been a big topic, especially relatively recently. We had one of our doctors, a Black doctor, she died. She was treated by one of our own hospital systems and was just absolutely maltreated. And she basically was getting blamed for being Black and being intimidating, et cetera. And she wound up dying. The hospital systems in Indiana have had a lot of backlash from the Black community, rightfully so. And there's 3 systems within within Indiana that do a lot of treatment. And so there was a whole entire webinar to hold them accountable, right? So we have Indiana Health, we have Eskenazi, we have Community, and the CEOs were actually interviewed by the Black community in terms of what are they doing to be held accountable. And it was a really, really interesting session where we heard from all these CEOs in terms of the strategic plans that are being put in place at each one of these hospital systems. And I think some of the interesting things that I heard were, in terms of what they're doing is obviously this has to come from the top down, and so these efforts include initiatives of incorporating issues around diversity, equity, inclusion in faculty development and annual reviews. So this becomes something that is an absolute priority, and it's illustrated through the CEO. So you are not, so as you are getting reviewed annually, that there needs to be goals on your annual review in terms of promoting diversity, equity, inclusion, and that you're being evaluated on those goals. What is your budget that you have at your hospital to change the culture and change the environment to increase education? These hospital systems were putting millions of dollars towards their budget in terms of changing the culture, getting the education, whatever that is. I know a lot of doctors, healthcare, like it's hard in terms of the time, it's not always practical. So there's a lot of money that goes into these education, but what are you actually setting aside for this? And even like reaching out and making sure that, so when you have the community that comes to your hospital, what is the workload, the diversity of your workload? Is it reflecting the community that's coming into your hospital? And it should not necessarily be this reflection at lower levels. It needs to be reflections throughout all levels of the entire hospital system. And so it's interesting too. So these institutions have to put their strategic plans surrounding DEI, diversity, equity, inclusion, on their websites, and they are all holding themselves accountable and making sure that these are measurable things that they're putting into place, and that they could be evaluated and held accountable for these actions.
Thanks, Dawn, for your comments. I'm sure Susan may respond. If I could make a comment before that. Hospital, from our personal perspective, anecdotally, I could say, unfortunately, unconscious bias, if not racism, is severe. However, I would also point it out, in June 2020, our CEO, Susan Acott, has actually sent an email to all its 1,000 staff, right, with the slogan, Black Lives Matter. Key point is the time, June 2020. In June, most of the people were neutral. And if I could quote, silence in the presence of oppression is complicity. Our CEO actually stood up even in June 2020, but I'm not sure whether the 8,000 staff actually listened to her, because the culture has to change as well. Sorry, Susan, make that comment.
That advice, actually. I think it really, it is clearly a very, very fundamentally challenging thing to change a culture, and so I'm sort of genuinely interested in other people's experience and advice, particularly when you're trying to get a large organisation to shift. I mean, it's like moving an oil tanker. So I think nobody. I don't necessarily have the answer, but it's about starting and trying and taking steps. So I think both from the American experience and also your own suggestions, Dr. Nagpaul, I've written them down, so thank you very much.
Right, if there is no more burning questions, then I would go for our next speaker, who will be Professor Mala Rao. I would.
May I say something, please?
There is a comment. Can I make a comment?
Okay, a quick one, please, Anil.
I was going to say, it's a very nice program. Thank you very much. And I work closely with Chaand, with Nitin and Ahmed. I can see a number of people who are active within the BMA. And I think my point will be that at any trust, Susan, there has to be a collaborative working with the medical staff, nursing staff, and other staff. So I think you need to have a very active BAM staff network within your trust, so that they can feed back to you outside the management structure. Because as a chief executive, you are surrounded by people in executive who don't, a lot of time, wouldn't tell you the truth, what is happening, what is the morale of the staff. And I think what you really need to do is give the grassroots staff, empower them, empower your BAM staff network, empower your local negotiating committee and the medical staff committee. These are some of the structure of the BMA, which, in a sense, the more collaborative working you will have at your trust, the more positive feedback you'll get, they will be happy, your patients will be happy. So I think, I believe that that's the approach you should take. Your trust is at multiple sites. You look after several hospitals, and you probably have about 40–50% staff who are certain medical staff who are BAME, rest of the staff probably 26%. So large number of staff BAME, and I think they have specific cultural needs. They have needs, which are different from the white staff, and you have to understand that. And I think Nitin mentioned to me that some of the structure at your trust regarding the senior management, you need to reflect on that there should be greater representation of BME staff within the executive and non-executive directors, so that they can make the change, which these colleagues very much deserve. Thank you.
Thanks for your comment. I
think there's a Jayashri or someone that quickly wants to say something. They have their hand up.
Okay.
What I actually wanted to say, can you hear me? Was
we can hear you.
That racism in any form really makes the system very, very inefficient. And especially in pandemics, when people face stigma, blame, we have a hierarchy of things. So when we're talking especially about inequalities, we mustn't bring in a hierarchy of inequalities and forget frontline workers like bus drivers, cab drivers, who suffer both socioeconomic, occupational, housing, other structural impediments which we as healthcare workers need to influence and highlight. We are quite in a privileged position to talk as healthcare workers about the pandemic.
Thank you for your comment. Can everyone see the slide that I'm sharing?
Not yet.
Okay, so I'll introduce Professor Mala Rao. It's an absolute honor for me to have you with us. Professor Mala Rao, OBE, MSc, MBBS, FFPH, PhD, and lots of other degrees, is a director of the Ethnicity and Health Unit and Senior Clinical Fellow at the Department of Primary Care and Public Health, Imperial College London, and medical advisor to NHS England's Workforce Race Equality Strategy, RES. Her career has spanned public health practice, policy, and research. She has served as a Director of Public Health in the 1990s and as Head of Public Health Workforce for England during 2004 to 2008, following which she was seconded under the aegis of UK-Indian Health Collaboration to be the founding director of India's first Institute of Public Health. Her past achievements in workforce development and health system strengthening have been groundbreaking in the UK and in the global arena. Her research, which has improved healthcare for millions in some of the poorest states of India, resulted in her inclusion among the 100 most influential people in India and UK relations in 2019. She has campaigned against racism in the NHS throughout her career. Her review of well-being in Black and minority ethnic population in England was launched at the House of Lords in 2014 and influenced the establishment of the NHS Workforce Race Equality Strategic Advisory Group, of which she was vice chair during 2016 to 2018. She was co-guest editor of the British Medical Journal's special issue on racism in medicine, published in February 2020, and is co-founder of the NHS Race and Health Observatory. She was included in the top 50 of the most influential BME people in the English health world, announced by NHS England and Health Service Journal in October 2020. Mala is also recognized champion of climate change action, safe water and sanitation. She is vice chair of Water Aid UK, a governor of Motability, and honorary advisor to a number of other charitable organizations. Professor Mala Rao, the floor is yours now.
Thank you so much, Mo. You're going to do my slides, I believe.
Can you see slide 1?
No, not yet. I don't know if others can.
Oh, I thought I've already shared the slide. Okay, let me restart.
Well, while you're getting the slides up, I mean, perhaps, you know, in the interest of time, let me just begin by thanking you, Mo, and Karen Saunders, and all the organizers of this meeting for inviting me to give a talk on evolving knowledge of vulnerabilities and unequal impacts during COVID-19. It's such an enormous privilege to have this opportunity to share with you my views and reflections on the ethnic inequalities which have been exposed by the pandemic, my views on why equality matters, and the crucial role I believe you all have in contributing to this goal. So if you go on to slide 2, please. History will remember, as has already been mentioned, history will remember 2020 as a year when two events collided, resulting in turmoil worldwide. I am, of course, referring to the COVID-19 pandemic and the killing of George Floyd, which resulted in an eruption of anger, pain, and grief, and a massive resurgence of the Black Lives Matter movement. And you know, just to remember the historic context as countries and communities grapple with the challenges of these two tsunamis, the link between these apparently unconnected issues began to be exposed, and the world woke up to the fact that the disproportionate impacts of COVID-19 on Black and minority ethnic people was explained in substantial part by the racism, discrimination, and socioeconomic inequalities which defined their lives long before the pandemic. Slide 3, please. Next. You know, it's important to look at the broader picture, which is one of widening socioeconomic inequalities. We are facing the biggest economic downturn in 300 years. People in the most affluent areas are 50% less likely to die of COVID than those in the poorest areas. Disabled people have 2 to 3 times you know, the death rates of the non-disabled people, as Joe Wiley has so eloquently alerted us to in recent days. 1 in 3 of 18 to 24-year-olds have either been furloughed or have lost their jobs. And data shows that household poverty is increasing. Next, please. Now, against that background, we've had 124,000 deaths in England as of yesterday, and now we know from that the risk of dying due to COVID is higher in males rather than in females, that is greater in people living in more deprived areas, and that this inequality in death rates is interestingly greater and more cruel in the case of COVID infection than in past infections, such as flu infection in past winters. And government's own analysis of the impacts published in November highlighted long-term deprivation which may occur, which will impact on access to food and malnutrition. I think Rosie Duffield mentioned these. Increasingly, possibly we are already seeing damaging health behaviors, and that already mental ill health, isolation, domestic violence, physical inactivity, all of these things are rising. Next, please. Now, against that background, of course, the evidence which has been exposed most starkly is the increased risk of infection in people of BAME communities, which began to emerge as early as last April when we observed their overrepresentation in amongst the critically ill, confirmed patients receiving advanced respiratory support. And these data
What does
started
it
to
say?
gather
When do we
in our
season it?
ICNOC
Soy
report.
sauce,
And
sugar,
after
sesame
adjusting
oil,
for
garlic,
age,
and cook and cover
compared with
medium heat
people
until
from
sticky.
white ethnic
Remove and
groups,
keep warm.
risk
Oh,
of death
okay.
due to
Turn over and
COVID
cook for 2 minutes.
is
No.
far
Can you
higher,
get
as you can see,
can you get a plate
in
for me, buddy?
Black and South Asian men and women with a hierarchy of risk.
Just to put the fish away when we
Black
finish.
and
Do you want to
African
squeeze
men
this
and women
garlic in here?
having the highest risk, followed by Bangladeshi, Black Caribbean, and Pakistani men and women. Next, please. The ONS, or the Office of National Statistics' own conclusion of this analysis was quite, was very interesting, and I quote: "Our modeling shows that a large proportion of the difference in the risk of COVID mortality between groups could be explained, as we know, by demographic, geographical, and socioeconomic factors and pre-existing conditions, but it does not explain the remaining ethnic background difference in mortality." And we
there's a piece
all
that fell down.
welcomed, did we not, the PHE's report beyond the data in June,
Oh,
which
should we get the
acknowledged
cabbage out as well?
that unexplained difference pointed to racism and discrimination.
Are we
Next,
having cabbage?
please. So, next, Mo, please. Mo, could I have the next slide, please?
Yeah.
In summary, if we look at the table of risks for higher infection and mortality, we find that the only mitigating factor for BAME groups is the comparatively younger population, although we know that many young BAME people too lost their lives due to COVID infection. Next, Mo, please. So moving forward, our PHE's review and other government strategies have systematically set out plans, many of which can only be achieved at the level of government. So if we look at, income and housing and social and some of those transformational changes that we need, if we are not to repeat the kind of BAME disproportionate impacts again should pandemics occur in the future, then this requires a bold action on the part of government. But there is also a call to tackle racism and discrimination within the health and care system, and that's where we definitely have a collective role.
And are we happy with cabbage? What do you want to? Do you want to find
in recognition of
a recipe to make Chinese
historical
cabbage dish something?
And
we don't have Chinese food, but
probably
no,
why
actually, we can just add
are less likely to seek care when necessary.
Yeah, fine.
Could I just interrupt for a moment?
A sorted one?
Yes, please. Shashi, you are the host now. You need to mute all.
Shoot, I hope it's not.
Excuse me. Yeah, Shashi, if you can mute all. The host function has gone because I'm sharing the slide. Okay. I'm the host now. Okay, thank you. Okay, because I'm in the sharing mode, I won't be able to mute all. Seems like. Okay, Mala, I think you can continue.
Right, thank you. Next slide, please, Mo. Perhaps it's next slide, please. Perhaps it's an appropriate moment for us to pause and remind ourselves of the first principle of the NHS Constitution, which pledges equity of access to its services. And also, if we look at the red, the line that I've highlighted in red below, and reminds us of the duty to pay particular attention to groups or sections of society where improvements in health and life expectancy are not keeping pace with the rest of the population. Next slide, please. So in my view, there are three broad areas where we need to act. First is to recognize that ethnic minority people have the greater burden of ill health. The health survey for England as far back as in 2004 showed that the health of white English people aged 61 to 70 is equivalent to Caribbean people in their late 40s or early 50s, Indian people in their early 40s, Pakistani people in their late 30s, and Bangladeshi people in their late 20s or early 30s. You know, aren't these shocking findings? And ethnic variation in access to healthcare is to be found everywhere. We could look at maternity, mental health, pain management, cardiovascular services, and the rest, and we will find it. And yet, you know, we've had this data for 3 decades or more. Where have we, you know, what have we done with it? Why haven't we acted? Next slide, please. So, little wonder then that we have these substantial levels of vaccine hesitancy in BAME groups. What came as a surprise to me when I was looking into these data was to discover that these variations merely follow historic trends of vaccine hesitancy and differential uptake rates for flu vaccinations, which we've seen last winter, the winter before, and so on and so forth. And this has never been highlighted, and we've never done anything about this in past years. Next slide, please. Second, there is the issue that population research has ignored ethnic minority people. In the Racism in Medicine issue, which I co-edited at the British Medical Journal last year, academics highlighted the risks of the general lack of representation of BME people, for example, in research into older populations. And what is more alarming is that algorithmic-based medical innovations such as artificial intelligence and digital health and so on, if not developed appropriately, could misdiagnose, underdiagnose, and potentially increase health inequalities. And yet in all of those, there is a vast and significant underrepresentation of BME people in the research. And research funders and journals have not used their influence so far to correct this imbalance. Next slide, please. And of course, this played out in the BAME underrepresentation in COVID vaccine trials and in all COVID studies, which were NIHR funded. Of course, you know, I've been wondering, does this matter? Since we're all biologically the same. And I was looking into this, and I came across this interesting quote of Professor Iverson of Oxford University, and an eminent immunobiological research scientist who's researching on HIV virus. And she has recently confirmed that it does. Her work has shown that inequalities in healthcare can affect pathogen evolution of COVID-19 and other population-specific effective vaccines in the future. So it does matter to ensure that we have adequate BAME representation in our research. Next slide, please. And of course, the third issue is to do with, Mo, could I have the next slide? The third issue is the one before, please. And third is the need to address racism in the NHS workforce. And Chaand has already spoken, you know, so eloquently on this whole issue. We need to honor the lives of the mostly BAME staff who died due to COVID, the tragic consequences, as he pointed out. We've had discussion on it. There are many cases of not having enough voice to demand even the basic protections that they needed to keep themselves safe last year. Next slide, please. When we look at reported discrimination by protected characteristic in our NHS staff survey, ethnic background continues to be the most common reason given for discrimination year after year. And the sadness is that it never seems to change. Next slide, please. I'd like to focus also, as Chaand did, for a few minutes on doctors, as that is the focus of my work as part of the workforce race equality strategy. And as he rightly pointed out, doctors from BAME backgrounds suffer disadvantage throughout their careers. Differential attainment by ethnicity persists across all measures of career progression, the entire training pathway, and in all specialties. As he pointed out before me, international medical graduates experience the worst levels of disadvantage. They're often treated with indifference and gap filler status. And so because of all of that, the priorities that I was set by all of you, the medical stakeholders, was to develop the MRES, so the Medical Workforce Race Equality Indicators, and an induction program for international medical graduates. Next slide, please. I'm not going to go through all of these indicators because Chaand has talked about many of them, and the indicators are based on a mountain of evidence, which I'm not going to discuss one by one. But I would like to draw your attention to the last point I've made in this slide, that the NHS staff surveys show that despite all the discrimination, BAME doctors demonstrate higher levels of motivation and engagement. They are proud of working for the NHS, especially the international medical graduates. It's time that the NHS was equally as proud of them. Next slide, please. And as this is a research group, hosting this event, I thought I must say a word about medical academia, because they too face discrimination. The Wellcome Trust, UKRI, all of them have acknowledged ethnic variations in access to grants and research opportunities. The Royal College of Physicians research has demonstrated that BME physicians appear to struggle to access research in some specific ways, citing culture of their organizations and lower levels of confidence as two important issues. And here then we wonder why there is so little interest in enhancing BAME public and patient participation in research. If we don't have the BAME academia, speaking up for BAME patients and the public, a representation in research, we're not really going to see much change in the future. Next slide, please. And of course, I would wish to say a word about women academics, because they actually have the worst experience in academia. The higher education data showed that more Black staff were employed as cleaners, porters, or receptionists than lecturers or professors in 2017. And qualitative research often comes up with this kind of statement: I've been mistaken for the coffee lady by Black women professors. And even the Athena Swan Charter, which compelled universities to improve gender equality in NIHR-funded research, has ended up with white women preferentially becoming the main beneficiaries of the Charter Mark Awards. Next slide, please. So what do we do to address all of this? I'm very proud that the Medical Workforce Race Equality Standards and Indicators, which I've led the development of since 2019, have now been published. The indicators have been published on the NHS England website, and I'm very hopeful that the data against those indicators will also be published quite soon, and that they will start to be collected at a national, regional, specialty, or other level, depending on what's most appropriate for each indicator, and that they will start to bring these data to every forum where these these sorts of matters are discussed, and that we will all be, if you like, obliged to start to improve the ethnic variations you're going to see when those data are published. Next slide, please. On the broader issue, how do we achieve equality in a post-COVID NHS? Real change requires transformational actions. It requires white and BME people working together. And as I think you mentioned, Mo, it's not enough to denounce racism. We need to be actively anti-racist and inclusive. Dawn Newman made these points a few minutes ago. And, in developing a post-racial way of doing things, we've got to acknowledge that it's racism, not race, which is the driver of health inequalities. And people with power and influence need to act as our allies. And it's fantastic to see your chief executive and your head of HR and so on being such good allies. And I just wish that they could be cloned right across the country. We'd probably have a completely different, culture across the NHS. Next slide, please. And I think Chaand mentioned this. What could we all do? We must get to know the facts and data highlighting inequity and act to address those persistent data gaps. It's COVID that brought to everyone's attention the fact that we don't collect ethnicity on death certificates in this country. A point when I look back at the BMJ, an ethnic minority psychiatrist had made this plea in an editorial in 1999, and we've done nothing about it. And COVID has compelled us to do something about that data gap. We need to build more racially concordant strategies for research and clinical care. We need to look at what we each can do in our spheres of influence, systematically decolonizing medical research, curricula, teaching, practice, whatever we have within our spheres of influence. And we need to challenge these inequalities, and there are sufficient fora now. We've got leaders like Chaand who have united us and who've given us that psychological safety to bring these matters together, and enlist him in supporting us to do something, whether it's about medical school leadership, NHS trust leadership, the dearth of BME faculty and their low success in getting grant funding, or whatever it might be. And we do it with like-minded people. Next slide, please. And in conclusion, there will, despite all of this evidence, there'll be people amongst us who will say, well, does any of this matter? It does. And there isn't just a moral case, but a very, very sound business case that could be made for race equality. For a start, the NHS staff surveys demonstrate that the extent to which an organisation values its minority staff is a good barometer of how well patients are likely to be cared for. So the CQC, come and note one thing, you'll find a correlation with the other. But the evidence from industry is even more compelling. McKinsey's series of 3 studies across 15 countries demonstrating a higher likelihood of outperformance with ethnic diversity than even gender diversity. And they were so struck by the significance of their results that they first undertook the study in 2014, they repeated it in 2018, and they repeated it in 2020. And these figures are absolutely compelling and consistent, that ethnic diversity is absolutely essential if you want to outperform others in your industry. So I would like to end, ladies and gentlemen, by saying we all have a duty, but also the influence to act on racism. And, I often remind myself of what this amazing civil rights campaigner, Reverend Al Sharpton, said. Let's all work to help turn the movement into a movement. So thank you all very much indeed.
Thank you. Right, whilst I'm getting back, you'll be, Professor Rao, your research point is very important. That is this underrepresentation of BAME in research, both as participants as well as researchers. So you'll be happy to hear that soon we'll be hearing Kent-based BAME COVID research, interim data albeit. And this could actually reflect one of my observations, I don't know whether it's true or not, that what Dr. Nagpaul was saying, that the fit testing is fails a lot of BAME people, it could be representing the fact that most of the research was done on the development of the that N95 or FFP3. It's the same thing. My dentist actually told me that the dental implant surgery is very difficult because my facial structure is different, because most of the research was done on Caucasian people. So that's why in all our research we try to put this caveat that there was sort of lack of heterogeneity. So our next speaker will be very eminent person, Professor and Dr. Anton Emmanuel. I think you'll be able to present from on your side. So I will try to get you. I will try to get you the presenting, requesting unmute, request send, and presenting authority. Don't know how to do that. Can you share your slide?
Yeah, I'm trying my best. I did and I asked to present before 7, so I could go and attend another webinar where I'm leading on.
Yeah,
so,
I found yeah, thanks. Professor Emmanuel, can I read and introduce you, please?
Probably not. I mean, I tell you what, I think it's best if as I said to you at the start of the week, Mo, I've got to leave by 7 to present on this other webinar with Prerna. So I'm going to ask you to please pull my slides and please pull my, I've been messaging you politely or quietly on there saying, can you fit me in before? And I did it at the start of the week. So please carry on with the rest of this. I've enjoyed what I've heard and I'm sorry I can't join you for the rest of the session.
Right. Okay, maybe we'll invite you to.
Well, if I haven't expressed myself, but as I said, I have mentioned this with good notice, and I'm really sorry. I can't let people down who are pre-ordered. So please forgive me, and I wish you well.
It's my apology. We got carried away with the time and on the IT to some extent. So hopefully we'll invite you for our next event in summer.
I'll be in disgrace by then, probably. All the very best.
Can we not ask Professor Rao any questions, Chairman?
Oh yes, please, yeah.
So can I say thank you, Professor Rao, for all the hard work you've done on the REST indicators, and especially since I'm a doctor, I've been really pleased that you've now published the medical REST indicators. It was only after COVID that I became aware of the REST indicators. And one of the things that has really frustrated me is that the REST indicators have been around since 2016. And yet it's only now, and a pandemic like this that is so, so clearly discriminating against the BME community, that we then start looking at these indicators. But things are what they are, and we are here. My question to you was, do you think that NHS England should be more active in making trusts more accountable for these indicators, since these are national indicators? And like many national things, should trusts not be able to show what have they done year on year when they are given this data? And should NHS England not make them accountable?
Yeah, thank you for that question. I had the great fortune of being a member of the Workforce Race Equality Advisory Group, which to begin with was chaired by Lord David Pryor, who is now the chair of NHS England. And then it was taken over by Keith Pearson when he became a junior minister in the health department. And so, you know, there have been eminent chairs. They're drawn from the NHS family, from the chairs of the NHS family of organizations. You know, it's been an interesting journey, and even getting the indicators embedded into routine annual data gathering across 231 trusts was a job and a half in itself, and that was done. But then actually the RES advisory group then began to notice that you could have really bad RES you know, data, and the trust would get an outstanding you know, inspection report from the CQC, especially in the well-led domain bit. And so the RES advisory group started to challenge CQC on how that could be, because, you know, there was evidently a mismatch and a lack of synchronization. And I believe that CQC, it's taken this long, I'm afraid, for CQC to start to find a way by which its well-led domain would have to take account of the RES indicators. And if the RES indicators are bad, then the CQC you know, report is going to highlight that. But the other thing is, you know how many times the RES team have gone round the country saying to every chief executive and every chair, because they've had their annual data since 2015, please at least discuss it annually at your board and ensure that all your staff know what those results are. And then beyond, you know, making that plea to 231 chief executives, there's this little that you know, the RES team itself could have done. But it's interesting how in some trusts, the BAME networks have taken it upon themselves to get to know what their data are when they're annually published, discuss it across the entire workforce, you know, compel the board to discuss it, and to discuss it with their HR teams, and to try and find ways by which things could get better and better in their trust. So it's a bit variable, and I'm hoping that this tragedy of COVID will accelerate the seriousness with which chief executives and chairs and boards will take the RES data and do something about it within trusts. So thank you for the question.
Mo, can I ask a question from Prof?
Yeah, sure.
Sure. Prof, I'm not really got interested in all this when the pandemic started. And what I'm surprised is when I looked at the data, the difference of life expectancy in the most deprived and the least deprived area, there's a difference of about 9 years in males and about 7.5 years in the females. We have this data for, you know, for decades, like not decades, for years. And then we look at the amount that the councils are spending on every individual within the local council. It is reduced all over the country. But the most reduction is in the most deprived area for around 30%. And in the least deprived area is around 16%. So, you know, even an eye doctor thinks this is not right. So why do we have to wait till COVID-19 to, you know, to look at this data? You know, we are talking about people's lives. And we have this data for years. And our government, our leaders are still spending less in areas which are most deprived. So how can we, you know, correct it? Or why is that in the mainstream media? Why do we have to look for this data and then get surprised by it?
Well, I mean, I have to say, you know, we're very fortunate to have your member of parliament in the group, and I wonder whether Rosie Duffield might have something to say. I mean, you know, to give governments their due, they do have hundreds of conflicting pressures on them. But I agree with you that our inequalities have continued to grow. Sir Michael Marmot is the spokesperson appointed by government to advise them and lead this whole, if you like, the investigation into our ever-widening socio-economic inequalities and what might be done about it. So we do need our government, and we have to keep making the case. And that's why in my slide, what I said was that the government's own assessment of what needs to be done in the post-pandemic era is very systematic, and it does acknowledge the need for massive socioeconomic, action to address those inequalities. But it also talks about racism and discrimination. And so I principally talked about stuff that's in our sphere of influence. But I work for charity. I work for Motability and some of these organizations, which gives me a little bit extra voice to talk about the lives of disabled people or whatever it might be. And I suggest we all get active in looking into these things within our spheres of influence, within the areas of our trust and where our patrons are drawn from, and to see how we can all contribute a little to that agenda. And we press government to do its bit to address these inequalities.
Yeah, this is the data when I was talking to Sir Michael Marmot, he basically told me about this. So he's the advisor. So it's nice to have good advisors, but we need to listen to the advice as well, probably.
Right, thank you. My sincere apology to Professor Emmanuel. He actually has had the data for RAS data for our hospital as well as the national average and how does it differ. So if Andrea or Susan would request for that data to be given, maybe that's the only way. I can't provide it. So our next speaker is Karen Saunders. Do you have the way to share your data?
Hello, good evening. I'll see if my slides, I can put them in. Hold on.
I've found a way to give you the presenters. Yep. Okay, so if I could introduce Karen. Karen Saunders is a specialist neurological physiotherapist with over 20 years of clinical experience working with survivors of brain injury and other neurological conditions. She is consultant research fellow for neuro rehab at East Kent and is a core member of this cross-specialty research team. Karen has extensive research and educational expertise and received a highly commended award recently from our trust for making an exceptional team contribution to research and innovation over the past 12 months. Karen is in her first year of a PhD scholarship award with the NIHR, National Institute of Health Research, Applied Research Collaborative for Kent, Sussex and Surrey. Her PhD is focused on co-production and clinical trial of a combined physical and mental health treatment intervention for brain injury survivors, that is my patients, who are living in the community. Even this evening, she will present an update of our ongoing current research into the impact of COVID-19 on the brain community in Kent. Karen, you can start.
Thank you. Can you see the slides on the screen?
Nope.
Bear with me.
Okay, yeah. So, I mean, this is a good news that in that competition for PhD, we won. There were 2 scholarship PhD available, and we won both. Okay, yes, sharing. Yeah.
We can see it now, Karen.
now?
We can see it.
I am hitting all.
Thank you. Good evening. It's wonderful to participate in our third live research event, and the presentations from Professor Mala Rao and Dr. Nagpaul have been extremely insightful and powerful. So thank you so much for that. So this evening I'm going to provide an update on our current research project into the experience of the COVID-19 pandemic by Black and Asian ethnic communities living in Kent. The research is led by Dr. Sakel and is a collaborative project between East Kent Hospitals Trust, the School of Psychology at Kent University, Kent and Medway NHS and Social Care Partnership Trust, and the Ethnic Minority Independent Council in Canterbury. To introduce this research, I'm going to briefly set the context and drivers for the research. And then to encourage audience interaction, I've created 2 questions for everyone to answer. How would you describe this presentation, and is there anything specific that you would like to add? So if you could kindly Google menti.com in a new browser tab and then add the code number on this slide, this will bring these 2 questions up. Because it's quite a useful interactive tool for very simple anonymous feedback. So we've now completed stage 1 of the research and have used thematic analysis to organise and interpret the qualitative data. So I'm going to mainly focus on sharing the preliminary themes identified within the data. These themes are now being used to construct a questionnaire for stage 2 of the research. And we will be pilot testing the questionnaire prior to dissemination to Black and Asian ethnic communities within the UK. Finally, I'll conclude with a personal reflection and a reminder of the code for the Menti. In May last year, the Open Safely Collaborative study analysed 17 million electronic patient records and identified that people with Black and Asian ethnicity are at a much higher risk of an in-hospital death from COVID-19. Our research aims to gain insight and understanding of the factors which may be associated with this. More recently, in February, an excellent paper was published supported by Anton and the RCP, which evaluated the risks of COVID-19 related death amongst 13,500 consultant physicians who work in the NHS. This study identified that 1/3, that's quite a lot, of consultant physicians have an increased risk of a COVID-19 related death, with 1 in 5 having a higher relative risk. This risk is mainly driven by age, gender and ethnicity, with the highest risk being male consultants over the age of 60, especially from Black or Asian ethnic backgrounds. This paper highlighted that individual risk assessments for all consultant physicians need to be in place. And I would like to suggest that these risk assessments should be under regular review. Stage 1 of our research focused on gaining insight and understanding of COVID-19 related experiences from quite a diverse group of individuals who identified as having a Black or Asian ethnic background. We conducted semi-structured interviews by telephone, and this slide shows the varied characteristics of the participants. So whilst our questions focused on 3 main areas, so knowledge, attitudes and behaviours, we discovered through data analysis that a much wider range of issues came to the surface. So it's worth taking a moment to look at this word cloud. This displays some of the anonymous quotes from our data from the participants, and I'm just going to pick out a few. I don't want to watch the news. And there was a sense from participants of being overwhelmed by bad news. And another participant commented that there had been so many deaths. And this appears to have influenced how people choose to gain information now, with many choosing to avoid watching the news to some extent, and some choosing to listen to family and friends rather than perhaps look at a newspaper or television channel. There were many comments on the sense of feeling more vulnerable and how this might affect future choices and life decisions. So, for example, changing career or changing life direction. We constructed a coding framework by taking a thematic approach and took a third-person perspective when we read the data. We are aware that no one is a tabula rasa or a blank slate. So we use the lens of autonomy, competence and relatedness to identify emergent themes. And these are the emergent themes that have come from our data. So I'm just going to pick on two to focus on for discussion. First being emotional impact, and this was described vividly around everyday scenarios now becoming fraught with anxiety and fear, and some sadness being linked to fatigue and reduced energy levels. There has been a psychological impact on both children and adults through the pandemic, and often confidence levels have been affected. Another theme that came out was the vaccine, and the vaccine was just being given to the high priority groups during our later interviews, and participants commented that to them it offered hope and they would be very keen to receive it provided it was safe. Participants expressed a sense of looking forward to the vaccine and hope that it would bring positive change to their experience of the pandemic in their everyday lives. Our research survey will incorporate this theme along with all the others and seeks to understand more about the disparities in uptake of the vaccine amongst Black and Asian ethnic communities. There was a recent article published in February in the BMJ by Professor Azim Majid and colleagues that also highlighted that we do need to understand more and we need to seek to redress the disparities in uptake of the vaccine, which endorses our data. So I've ended on a simple reflection at this stage, and we hope that the research knowledge generated by the study will support and enable better informed discussions regarding how best to support the ongoing development of public health and educational policies to support UK BAME communities. And if audience members would kindly keep the 2 minute questions, we would very much appreciate that. So thank you very much for listening.
Thank you, Karen. We will have 2 more presentations. Okay, if you can put the Menti code in the chat box so that people can do the work.
Sure.
And so, and we'll have a panel discussion for question and answer after the next 2 presentations. So Aftab, you'll go next. So if you can unmute yourself.
Sure. Can I share my slides?
Yeah.
I'll try.
Yes.
Okay. Let me see.
After that, Professor Laurie Walton will talk about COVID impact on domestic abuse.
Okay. Can you see my slides?
Nope.
Nope. All right. What is that? Let me try once again. Share. Can you see it?
Yes, yes,
Yeah,
yes.
All right, that's great. All right, okay, good. Fine. So first of all, thank you, Mo and Karen Saunders for, inviting me and allowing me to share results of a few surveys that I have done recently. It's a continuation of my talk, which I did in your last event, regarding whether racism exists in NHS or not. So let's see, right. So we all know that unfortunately, for whatever reason, UK has one of the highest death rates of healthcare workers in the Western world. And we also know, as we have heard from the previous speakers, that disproportionately doctors and healthcare workers for ethnic minorities have suffered from COVID-19 virus. I think somebody is not muted. Right, okay. So we know that more than 95% of doctors who sadly lost their life were from ethnic minorities. So there's a perception, rightly or wrongly, that maybe the NHS response to COVID-19 risk mitigation would have been different if it were the white colleagues who were being disproportionately affected. Whether there's any credence to this perception, I'm not sure, but at least that is a perception among some colleagues. So I did this recent survey with about 785 respondents, and this is a recent survey. So it's not a survey in the start of the pandemic when the assessment was being rolled out within the NHS. And now when I asked the question that if you had a risk assessment, are you satisfied with the outcome? About 25% of the BME healthcare workers said that they were not satisfied with the outcome, as compared to less than 7% of the white healthcare workers. So there's a significant difference, much more than what Chaand showed in the BMS survey. And mind you, these are not only doctors, these are nurses as well. And when I did a subgroup analysis and looked at the international medical graduates, I was surprised that the difference in satisfaction from the risk assessment still remained the same. The BME international medical graduates, about 26-27% said that they were not satisfied with their risk assessment outcome, as compared to less than 6% of white international medical graduates. When the question was asked whether you have any problems assessing appropriate PPE since June 1, 2020, you can see again there's a significant difference between the BME healthcare workers and the white healthcare workers, with about 25% of the BME healthcare workers saying that they had problems assessing appropriate PPE as compared to 16% of white healthcare workers. When a question was asked, does your present work environment give you confidence to raise your concerns? As we heard earlier, because this survey is not limited to doctors, I think there's a significantly more difference than what Chaand was showing in his earlier talk. About 45% of the BME healthcare workers said the present work environment does not give them confidence to raise their concerns, as compared to 24% of the white healthcare workers. And surprisingly, when you do a subgroup analysis and look at BME healthcare workers who are from UK, have studied here in the UK universities, still 45% of them do not feel that they're confident to raise their concerns. It's not only the international medical graduates or doctors who come or nurses who come from abroad, it is also the doctors or nurses who are born here and studied here. They still, for whatever reason, are not confident to raise their concerns within their organizations. So I did a survey last year in April, May, in the start of the pandemic. I just show you a couple of slides from that survey. When in April last year, this is BME healthcare doctors, only BME doctors in the NHS, more than 1,000 doctors. When you ask them the question that, do you feel adequately protected with splash-proof masks while seeing suspected or COVID positive cases, about 79 to 80% said no. And when they were asked whether they feel better protected with FP3 respirator while seeing suspected or COVID positive patients, nearly 95% said yes. That was last year, before the Kent variant, which is much more contagious, was predominant variant, which is all over the country now. That was before the emergence of this new variant. That was before the emergence of increasing evidence that airborne transmission of this virus occurs. And the BMA wrote to the PHE last month, asking them to review their PHE guidance about PPE. But to date, it hasn't been reviewed. There's also a perception among some BME doctors that during the pandemic, somehow they have been rostered into the rail front line, into more into A&E or into COVID positive wards more than their white colleagues. So when a question was asked if there have been changes to your working pattern related to COVID-19 pandemic, were these changes happened with your agreement? About 50% of BME doctors said no, as compared to 29% of the white doctors. So this is a survey that I did in January regarding the decision of the chief medical officer to delay the second dose of Pfizer COVID vaccine. I know we all know about this. There is evidence and that if you delay the second dose of Oxford AstraZeneca vaccine, then to 12 weeks, then maybe its efficacy may even be better. And there is evidence to back this up. However, JCVI have postulated that if you delay the second dose of Pfizer, then maybe the efficacy of the first dose will remain till 12 weeks till you give the second dose. And there's a public health argument behind it because it will allow more individuals, more vulnerable population to have their first dose. And recently, the data has come, real world data from UK has come, which has showed that if you give the Pfizer first dose, you get protection from hospitalization from about 72% to 74%. And if you give the second dose, you get a protection of about 86%. While in Israel, it has been shown in a recent study published in New England Journal of Medicine, that if you give the second dose in 3 weeks, protection is about 95%. But even if you give the second dose with a little bit delayed, you still increase the protection by 14%. So when I asked the question from colleagues that has the government provided satisfactory evidence and justification for delay of second dose of Pfizer vaccine, nearly 95%, more than 95% of the colleagues said no. And when I asked the question, do you really feel stressed by this decision of the chief medical officers to delay the second dose, which nearly 90% of them said yes, extremely or moderately stressed. So I leave for you to decide whether there is any credence to the perception among our ethnic minority doctors that maybe the COVID-19 risk mitigation steps taken by NHS might have been different if there were other white colleagues who were being disproportionately being affected. Right, now this debate regarding racism NHS is based upon indirect evidence, like probably the evidence that I've showed, that has been showed earlier, anecdotal examples, personal views and experiences. But I feel that if we are serious in tackling discrimination in NHS, then we must be bold enough to do meaningful surveys which ask the right but difficult questions about racism in NHS. And to me, there appears to be a lack of such surveys. You know, we need to ask questions. We need to understand what is white privilege. What does white privilege in NHS means? Because unless we know what white privilege in NHS means, we cannot tackle it. We need to understand unconscious bias, and we need to understand, does overt racism occurs in NHS? So in this recent survey, I asked a direct question. In your opinion, does racism exist in the NHS without taking into account patient behavior? So I'm asking a question without taking into account patient behavior, right? About 80%, more than 79% of the BME healthcare workers said, yes, in their opinion, racism exists in the NHS. While nearly 40% of our white healthcare workers says, yes, the racism exists in the NHS. When I asked the question, have you personally experienced racism in the NHS without taking into account patient behavior? Nearly 67% of the BME healthcare workers said, yes, they have personally experienced racism without taking into account patient behavior, as compared to 17% of the white healthcare workers. So when you ask the question, that have you experienced verbal or physical abuse based on your race by your colleagues? I'm asking by your colleagues. More than 18% of our BME healthcare workers said that they have experienced verbal or physical abuse. To be honest, this surprised me. If I knew that there would be such a high percentage, I might have worded the question differently. I might have asked for verbal or physical abuse separately. I would thought, maybe 1% or maybe none. So, 18% or 19% of our colleagues are saying that they have experienced verbal or physical abuse by their colleagues. And more than 50% says that colleagues have made assumptions about their ability or behavior based upon stereotyping their race. They feel, more than 50% feel that they've been treated differently by colleagues because of their race. And around 45% of them feel that they are not always included in work or social events because of their race. There's some comments in the free text box. These are the comments that I can share. There's some comments that probably are not appropriate for public consumption at the moment, probably. So you say, you're all right for your kind. Because I don't drink alcohol, I'm mostly not invited to social events. I have often felt undermined based on ethnicity. Wouldn't know about colleagues having gone for social gatherings until they discuss it later. And the simplest one is where non-ethnic colleagues say, it's too difficult to pronounce your name, we will call you Fred Jane instead. Or the time when a consultant colleague, on finding me reading a Charles Dickens book, said, I had no idea you people had even heard of Dickens. Easy and familiar use of racial slurs such as, what was all that jibber jabber, after hearing two minority colleagues talking to each other in their language. So I asked the question, if you have witnessed racism at your place of work, what action did you take? More than 44% of the BME healthcare workers who have witnessed racism did not take any action. We need to change this. We need to create an environment where people are happy to raise their voices. And then I asked the question, if you took action when you witnessed racism at your place of work, what was the outcome of the action? Only 22% of colleagues said if they raised their voice, they were satisfied with the outcome. Nearly 78% of the colleagues were not satisfied with the outcome. The issue was not resolved. The action worsened the situation, or the complaint was ignored, or no action was taken. When the question was asked, if you have seen racism, why did you take any action? Was there a particular reason for that? More than 58% of colleagues said they feared the consequences. More than 58% feared the consequences of raising their voice. Right. So I really like this saying, justice will not be served until those who are unaffected feel as outraged as those who are. And it's a big challenge. As you can see with these, some of the comments that I have put in from the same survey from white colleagues. These are from white doctors. Witnessed colleagues in a discussion denying white privilege and complaining about movements and schemes that promote equality and diversity as being unfair to white people. No one from BME community was present in the room. In fact, we have very few BME colleagues. I'm seeing racism against white males. There's no active discrimination against whites. I think this is a problem. We need to have white allies, not, not colleagues who think like this. We need to think what we are doing or how we are going to tackle it. And I really can't help sharing this tweet, which I did about this program by David Harewood. I think it was titled, "Is COVID killing people of color?" And at the end of that program, there was a small clip of his question answers from our Equalities Minister, Kemi Badenoch. And I was surprised that she, denied that there's any evidence which can show that structural racism could be the cause of the health inequalities which have caused the disproportionate effect of COVID-19 on our ethnic minorities. So we have a big challenge. We need to get our leaders to understand this, our leaders to agree to this, that there is a problem, which is structural racism within the NHS, within the whole society. So this, let's go back. So institutional racism or unconscious bias in NHS, whatever it is, it cannot change till the NHS hierarchy represents the ethnic diversity of its workforce, in my opinion. We must remember that diversity is not merely about numbers. Getting a black or a brown person onto the board or executive in an effort to appear inclusive, these gestures of yesteryears will not be enough. This is a comment again from the survey. Have definitely felt more vulnerable and more likely to be targeted for raising same issues as a non-BME colleague. Even the few BME managers that are there expect the BME consultants to shut up and get on with it without rocking the boat, even for valid service-related issues. So we need to get the right people, whatever their color is, in right positions. We need leadership which is authentically inclusive and creates a culture that embraces diversity at its core. The discrimination, inequalities within the NHS need to be addressed, not just by words, surveys, but by meaningful actions. Let this be a watershed moment for bringing meaningful change into the NHS to end discrimination. Yeah, and just to show how big the challenge is, we all have seen probably the snowy white peaks, the Roger Klein, report, 2014 report, which highlighted the absence of Black and minority ethnic staff of NHS at senior levels. And there's one of the tables from that report which showed that there are about 8% nurse managers from BME community between 2003 and 2012. Their representation did not increase. And this is the data from 2019. If you look over here, it's still 8% in the higher levels of agenda for change employer colleagues. So nothing has changed in 7 years. It's a big challenge. We need to do something practical rather than doing studies. Thank you.
Thanks, Ahmed. Right, we will need straight into the next presentation by Professor Laurie Walton. If Laurie, if you could put your video on and audio on, then I can give you the option for presenting. Okay, right, thanks. I'll just say a few words about Professor Walton. Professor Laurie Walton is a professor at the University of Scranton in Pennsylvania, where President Joe Biden is from. He is also an honorary professor at the Bangladeshi Health Profession Institute in Dhaka, in Bangladesh. He has 15 years of academic faculty experience in the USA and over 20 years of experience as a licensed physical therapist. I'll skip most of it. Laurie and I are doing several research projects and lots of publications we already have, and long COVID studies coming. She has got another attribute. She's a strong advocate, scholar, and volunteer for multimodal rehabilitation programs for vulnerable populations across the world, and has spent time as a professor at the United Arab Emirates for 3 years at the University of Sharjah, where she provided classroom and clinical teaching for physical therapy students from across the world. It's a privilege to have you, Laurie, to talk about other vulnerable groups, what we call coerced through. Yeah, thanks.
Thank you, Dr. Mel. I'm having trouble. It won't allow me to put my PowerPoint without shutting my computer down completely, which will take too much time, I'm afraid. Can you upload it and help me with that so we can?
Okay, I can do that from here.
Sorry.
So I give your presenter authority back to me.
Okay, I don't think I took it.
Oh.
Do you have it? Is that correct?
Yes, I have your presentations.
Okay, well, while that's coming up, I'll just give a bit of introduction and background to my own research. My research is primarily with trauma and vulnerable populations of women, including refugee women in the USA and in MENA and Southeast Asian countries, including Pakistan and Bangladesh. I will discuss the impact of COVID-19 on intimate partner violence, which is taking a little bit of a turn from us talking about healthcare workers and physicians, but hopefully we'll capture the intersectionality of some of the issues that women have with IPV during the lockdown period.
Yep. It's coming up. Let's see.
Yes. Okay, next slide.
Is this slide one? Correct.
Next slide. Okay, this is original artwork by Salma Mohammed Jihan. The UN Declaration on the Elimination of Violence Against Women set out to acknowledge violence against women as a global public health problem and to define it. Next slide. It is defined as any act of gender-based violence that results in or is likely to result in physical, sexual, or psychological harm or suffering to women. It includes threats or such acts of coercion, arbitrary deprivation of liberty, and may occur in either public or private or both. Next slide. In 2017, the World Health Organization data reported that 1 in 3 women have been a survivor of IPV. Furthermore, it reported homicide prevalence through the Violence Against Women report at an astounding 38% globally. And even more astounding is the 41.2% that was reported in high-income countries compared to the low and middle-income countries, which had very similar rates, with the exception of the Eastern Mediterranean division and the West Pacific division. Southeast Asia held the highest IPV reports with 58.8%. IPV patients utilize more health resources than any other patients, and this utilization continues even 16 years after the abusion date. Women who experience IPV have 42% more annual health costs than any other patient. Yet, less than 1/3 of all healthcare providers report screening for any type of IPV on a routine basis. So why do we focus on women in this report when men also experience IPV? Well, let's take a look at the gender divide on this subject. Though 1 in 3 women and 1 in 4 men have experienced IPV, IPV for women is far more dangerous than for men. As you can see, 1 in 4 women and 1 in 7 men have been a victim of severe violence. 1 in 7 and 1 in 7 women, and yet 1 in 25 men have been injured by IPV. And 1 report being raped by IPV, and we do not have data on men at this time for this. Next slide. Across the globe, the rates of IPV remain high, with Southeast Asia, Sub-Saharan Africa, and Eastern Mediterranean region leading the number of IPV cases at 36.6% to 37.7%. However, the American region, European, and West Pacific regions are really not that far behind in prevalence of IPV. Next slide. Lifetime prevalence is compared in these two charts. The one on the left is for those who had ever been partnered in their life, and the one on the right side is those who've experienced gender-based violence and IPV by a non-partner or partner. The prevalence for both is stunningly high, as you can see. Next slide. There was an expected or predicted rise in IPV worldwide during lockdowns by the UN Population Division that increased from 31 million at 6 months of lockdown to greater than 45 million after 9 months of lockdown. Women also lost reproductive rights and control during this time, creating another devastating blow to women's autonomy and creating high-risk environments for IPV to occur. Next slide. You can see the IPV reports from police in the UK and how they increased from 2018, 2019 into 2020 during the pandemic. So we have an ending of 206,492 cases of IPV that were reported, much higher, but it looks as though there may have been a trend. We don't have full information on that. Okay, and next slide. This is very interesting. In the US, there appears to be a sudden rise in March of 2020 in IPV-related calls and reports, and then a dip in April of 2020. So I don't know if any of you know this that are not from the US, but in April is when the stimulus checks came out. I should say the stimulus check came out because Americans got one stimulus check. So this is attributed to that economic support for families during that month of April, because then it began to rise shortly after that, the end of May and up in June again. In Denmark, you can see that the domestic violence hotline initially spiked during the beginning of pandemic, and then it decreased through April and leveled out at the usual reported levels for the rest of the time. This is partially due to the fact that Denmark is a country that hosts cash flow assistance and loan guarantees for all of their citizens, and salary guarantees and sick leave payments, as well as support to local businesses and tax on a monthly basis at a rate of $3,800 US dollars per person. Next slide. The global impact of IPV since lockdown has shown a 650% spike in internet searches for domestic violence help in countries across Europe. Since then, IPV reports spiked all over the world in places like Singapore, Cyprus, France, and Argentina by 25 to 33%. Next slide. The Brookings Institute report on African countries shows a decrease in searches for IPV until December 2019, and then a sudden spike of internet searches for domestic violence throughout the pandemic in countries like Nigeria with the highest spike. Kenya, steady climb along with it and reaching almost equal levels towards April and May. Uganda and South Africa with a steady climb until April and then a spike in searches. And Egypt, where the cases began to climb in January and then spiked in May and June, when the cases of COVID were also increasing and lockdowns were implemented. Next slide. Post-pandemic reports from Mexico show an increase from pre to post-pandemic IPV and gender-based violence and crimes related to domestic violence in Mexico, though IPV reports remained the same. This is important because the hypothesis is that women may have been restricted in their ability to report IPV incidents, and this resulted in criminal offenses that were related to domestic violence instead increasing during the lockdown period. Next slide. In Latin American countries, such as Peru, the calls to helpline for IPV can be seen to have increased from March and then spiking upward in April to July, and then leveling off at a new level of IPV reporting that is 15,000 more than previous levels in 2018 and 2019. So we can see the trend across the world. Next slide. 243 million women have reported sexual and/or physical violence in the last 12 months worldwide. Domestic violence shelters have capacity with survivors of IPV, as hospitals have also reached capacity treating COVID-19. Social distancing measures taking women in during lockdown because of the mandatory 6-foot distancing rule. In some cases, the shelters are also being diverted to be used as health facilities for COVID. Slide. IPV encompasses, next slide. IPV encompasses all spokes of the power and control wheel. Issues such as coercion and threats, intimidation, emotional abuse, isolation, minimizing, denying, and blaming, using children to manipulate, using male privilege, and economic abuse. All of these have been shown in the literature to have been increased during pandemic. Next slide. As we're considering IPV, we must now take a deeper look into the intersectional variables that create cumulative trauma for certain populations because of the interconnection of race, class, ethnicity, religion, etc., as it applies to overlapping and interdependent systems of discrimination or inequity throughout our society. The term intersectionality is rooted in Black lesbian feminism in America and was a mechanism to understand the cumulative trauma and inequities that were present and presented as unique to Black women in America because of systemic racism and sexism. Next slide, please. Here you can see an example in the USA NISVA study showing differences in IPV lifetime reports, with multiracial non-Hispanic reporting the highest levels of IPV at 57%, Native American, Indigenous American, Alaskan Natives at 48%, and Black non-Hispanic at 45%, compared to their white non-Hispanic counterparts of 37%. When we overlay race with socioeconomic resources, we will see that areas of IPV tend to increase when there's a lack of socioeconomic resource support, and they decrease when families are directly economically supported through jobs, insurance, and other monetary support in their communities, regardless of race. Key to this is economic support, job stimulus, and access to key health and social services that are equitable across the races. Next slide, please. When considering the intersectionality, next slide. Oh, sorry, no, this is, never mind, this is correct. When considering the intersectionality of sexual orientation and gender identity, women across the board report the highest prevalence of IPV and sexual violence, with bisexual women reporting 61% prevalence of IPV compared to bisexual men at 37%, heterosexual women reporting 35% compared to men at 29%, and lesbian women reporting 44% compared to gay men at 26% prevalence of IPV. So all are significantly high reports overall, but there's a significant difference between the reports in all categories for women compared to men. Next slide. This should say 1 in 3, it says 1 in 4, but it's 1 in 3 women and 1 in 2 transgender women will experience GBV in a lifetime or IPV in a lifetime. Financial security is the #1 reason survivors do not leave the abuse. Again, economic, financial, economic. I want to emphasize that. $104,000 US is the average cost for being a female survivor of IPV in America. 99% of survivors experience ongoing financial abuse as part of the IPV in the form of control of assets, paychecks, children, household needs, as well as domestic servitude and labor within the home. Next slide. What are other factors that contribute to, So you can see clearly on this slide, the lifetime prevalence cost of IPV for a female is approximately $75,000 more per incident than for males. Medical costs are in the trillions. This again is a US study. And in addition, IPV contributes to trillions of dollars of lost work, criminal justice costs, and government funded programs for the aftermath. So prevention and public health pay in this matter. Next slide. What are the other factors that contribute to IPV during COVID-19 lockdown? I won't mention all of these, but we'll go through some of them because of time. So women as caregivers in the home, more women living with the perpetrators of violence for longer hours and demanding more in the household also present a unique situation in that they were unable to report because their perpetrator was there. were reporting that they were unable to report until he left the house to go and smoke a cigarette or to go out for food or to leave the house in some way. So women's employment levels, women's income levels, and poverty during pandemic increased, creating a situation where women who could have left otherwise difficult and abusive situations would have difficulty leaving their perpetrator, especially if they had children. So this is even more prominent in low resource countries and low resource areas throughout individual host countries. Confinement of women during COVID increased during the, according to UNDP, and this was also an excuse for perpetrators to use control and keep women within their homes during this time. So COVID lockdown was also used as a part of a manipulation or coercion for women. There's a report of the lack of ability to report IPV worldwide because those perpetrators are at home. In America, policing is a reach where 22% of all IPV cases are by Black men. However, the incarceration rates of Black men due to IPV charges are 66%. Again, pointing out the great systemic inequitable treatment of Black Americans. Furthermore, Black American women who reported IPV were more likely to be ignored or arrested themselves than any other race in America. So we must do more to address these inequities and protect, support, and help to rebuild our most vulnerable communities. Finally, consideration of the extra labor burden should be considered. Next slide. Okay, so who are these most vulnerable groups during COVID-19 that have experienced higher impact rates of IPV? Refugees, immigrants, and all internally displaced people or stateless people are at higher risk of IPV because of the lack of legal status, legal recourse, legal support, lack of economic resources, and opportunity for great abuses within and against the community from its host country. Women living in poverty, especially single mothers and young mothers, particularly between the ages of 15 and 19 years of age, Indigenous American, Canadian, Australian, Indigenous groups across the world, and from African heritage have shown a direct increase of IPV compared to others by 5 to 7% more. Lesbian, bisexual, and transgender women were forced to leave their homes at higher rates and become homeless during the pandemic, and this put them at greater risk also for IPV and gender-based violence. Women and disability are 2 to 4 times more likely to experience IPV during COVID lockdowns than any other time. We can also investigate women with mental illness, domestic and migrant workers living abroad, women living in polygamous relationships who don't have any legal status to be able to claim health benefits and or may be fearful of the perpetrator. All of these issues that are listed here can be considered. I don't have time to go into them now, so let's go on to the next slide. Okay, so what do we know about IPV? I think we've covered this. I've done a lot of research on trauma and how it relates to health outcomes, particularly physical and mental health outcomes and executive function. And it's found that 2 or more major traumas in women with low socioeconomic background have shown to have a significant increase in their executive dysfunction and their health-related quality of life, both physical and mental. This slide also gives you an overview of the holistic trauma that's experienced, and you can sort of see the cycle of that trauma and the effects. Okay, next slide. There's multiple pathways through which intimate partner violence can lead to adverse health outcomes. This figure highlights 3 key mechanisms and pathways that can explain many of these outcomes. Mental health problems and substance abuse may result directly from any of the 3 mechanisms, which might in turn increase health risk. However, mental health problems and substance abuse are not necessarily a precondition for subsequent health effects and will not always lie in this pathway. And then we have the childhood experiences study on the left from Johns Hopkins University, my alma mater, that is showing the systemic conditions of generalized embodiment and historical trauma social conditions that lead to those adverse health outcomes that lead to eventually an early death. Next slide. Okay, so I'm not going to go into all of this right now. There's some tools there you can use, but the World Health Organization at this time has not recommended universal screening for all patients of IPV. This is a real divide between what the American system decided in the Institute of Medicine a few years back. In America, we decided that the reports and the research supported universal screening of all women, and that it should be implemented. So we're hopeful that the World Health Organization will also move in that direction towards universal screening for IPV. Okay, next slide. I'd just like to point out, in communities that distrust police, such as those in America, we must take a framework of empowerment and race equity and move forward toward less incarceration of the perpetrators and more gender transformative approach that include families in the solution and include safe places for women and transitional housing and economic stimulus in the areas where the IPV is increased. Okay, next slide. This is a reminder we should also always use a gender transformative approach to interventions for public health perspective, including all of the intersectional causes of health inequities. Next slide. This is a trajectory to safety for health professionals who wish to respond to women and don't know what to do to report IPV. And next slide. A reminder that IPV is affected by social inequities and norms, community level issues such as diminished economic opportunities and residential instability, relationships within and outside the family, and individual issues related to low income, alcohol, and history of trauma. Next slide. Many of our failures victims during COVID-19 pandemic were related to accessing resources, shifting work from work to home environment, volunteers suddenly dropping out, increasing stress and responsibility of staff, reduced time, reduced availability of PPE, etc. Next slide. Here are some meager suggestions for best evidence and successful implementation of IPV programs to address this ever important issue in public health. I would like to, out of this whole list here, I would like to emphasize the strengthening of economic support for families and providing equitable services in healthcare and food assistance for all of those families as well. Thank you.
Thanks, Professor Walton, for such a comprehensive presentation. We would now go into a panel discussion. So I will try to unmute all. Yeah, so all attendees can unmute themselves and get to a question and answer. Right, and I would say,
Laurie, I like to really good presentation, really gripping presentation. I have one question, if you don't mind. The slide that showed the violence, the uptake of violence during the pandemic, there was an initial dip from a baseline. Now the baseline was higher, and then there was a dip before the pandemic, and then it went up again. Do you have any explanation for that?
I'm not sure which slide you're referring to.
There was a slide
in the US and
yeah, with the domestic violence.
And Denmark?
No, there was a slide showing domestic violence in relation to when the COVID-19 pandemic started. So it was around that time where there was a dip, and then it rose again.
I think you're talking about the different countries.
Okay.
Is that correct?
Yes.
I don't have it. I can't pop it up there in front of you. But the dip started in December 15, and then it started to rise across the world. So this was specific to African countries. This was one study that had been done. This study has not been done in multiple countries, so I don't have that information.
Sure.
But in Africa, that was 2019 was the beginning of the rise of IPV. And then you said that the dips, so the dips that you see were correlated also with either the lockdown being taken off or stimulus checks being placed in, depending on the country. So there's too many countries, I guess, for me to capture that in,
Thank you.
in one. It varies across the countries.
Sure. Thank you.
Okay, is there anyone else wish to ask any question? Just to mention that in our next event in summer, we will have a full slot for COVID impact on LGBTQ. So your presentation will lead into that nicely. So if I could request the panel members to put the video on so that we can see. So that's Nitin, if you are still there. Professor Mala Rao, yeah. So if there is, it is now open for any questions. I know it's all 8 o'clock. Actually, we are still ahead of time. We're doing okay with time. Just in the first session, I think we overran. We'll get next time.
Can I ask a question from Professor Rao?
Yes, please. Go ahead.
Prof, in these surveys that we do for the NHS National Service, why don't we ask direct questions? Difficult but direct questions about racism or discrimination.
Which national?
Do you have a national staff survey? We have a national staff survey which says, have you been bullied, harassed? Why can't you just ask, have you been racially bullied, or have you, about direct questions so that we can really know whether, because I was extremely surprised to say that 18%, although it's not like a national survey, but it's about 780 respondents, that 18% of colleagues said that they have verbal or physical, I'm not sure, can't be physical, but verbal or physical abuse. I just put it in without thinking that there would be anyone. This is direct, so I was surprised by that.
I believe that there are some NHS staff survey questions from which you can extrapolate whether the view, well, at least the perception is that they've been discriminated against because of their, perhaps their sexual preference or their gender or ethnicity. Is one of the things that's definitely quoted by Professor Jeremy Dawson, who leads the analysis of the NHS staff survey. Sheffield University is commissioned to do it. Always claims that ethnicity is often mentioned. In fact, it's the most frequent category given for discrimination. So, so I think one of the questions does allow you to get that information.
Yeah, where you saw this, I think there's a slide in your presentation about it up to 2018. But if you extrapolated 2019 survey shows that the racial discrimination goes up rather than going down between 2018 and 2019. I think you went up to 2018. So just something. So because we don't ask not direct questions, then we have our minorities ministers coming out to say that she still needs more evidence. Right.
It's a problem. I'm afraid that's a challenge for us. In the same way that, to some extent, we've had wonderful presentations here from American colleagues, and I often look at the US, which has got a far better and a longer track record of race and health type research than we have. They've had their difficulties over the last, few years with their political policies, I'm afraid we are still seeing that. Look at the widening inequalities. Look at the kinds of people who now represent the ethnic inequality agenda in government, talking about how critical race theory is rubbish and ought to be banned from ever being taught, and claiming that racism doesn't exist. So we do have a problem with our political leadership, and that's something to be tackled. And I hope we'll be inspired by the US to find ways of systematically engaging our policy people and our politicians to recognize the fallacy of and the dangers of to themselves and to the whole nation of encouraging inequalities in the way that governments do, unfortunately.
If I could request everyone to actually respond to that Mentimeter poll. I don't know what the Mentimeter code was. I don't know how many people have actually done it.
I think Karen has sent a link on the chat. Thank you, Professor. Mo, I think Professor is saying she needs to go.
Yeah, I think thanks, Professor Rao, for kindly spending so much time for us. Thanks. My apology to Anton again.
I'm sure he'll come back next time. Thank you. Thank you for a super session. Thank you.
Thanks.
Bye-bye.
Bye-bye.
Okay. Yeah, if there is any question around, otherwise, Dawn has a question, yeah?
No, I just wanted to kind of continue and build on what Dr. Aftab was saying in that presentation. And I did see there's a comment in the chat box about how racism is so difficult to prove. And so you have, this survey about have you been bullied, et cetera, and all of this stuff. And, these are what, at least in America, we call these, microaggressions to some degree. And a lot of times they're not even micro, they're very macro. And, I think that there's, you go into this unconscious bias and kind of, there's so many layers to this, whether or not people are consciously making these transgressions or whether they aren't. But, there's to some degree, it's one of those things where if you're a white privileged person and somebody's making these comments, they have no understanding and recognition of the transgression that they did. So if somebody says, you've made this comment, it's offensive to me, the likelihood that this white person, if they don't have a full understanding of this, that they're even going to take accountability or even listen to, what it is, the harm that they cause, they're going to be in complete and utter denial. So it's almost like trying to prove, to some degree, when you talk about sexual harassment, trying to prove that you've made this offense on, to somebody.
I actually think there's been some research, Dr. Dawn. I believe there's been some research on the different perception of racism in America anyway, coming from a neurological point of view. I don't know if you have any information on that or not, but the two different mindsets, yes, we do. And I think Dr. Rao was speaking to that when she was saying they were trying to do away with critical race theory and all of this within the UK. And I think it would be an interesting study too. I know you do some of that research, so I think it would be interesting to take on even further. So.
Yeah, I don't actually have any information on that. I really am at the very beginning of it, embarking my research to include, structural, systematically studying.
It's such a difficult thing to maneuver when you're discussing an issue like this with someone who doesn't acknowledge it. The implicit bias is not even realized. It's a difficult topic.
Exactly, and I think that that's where I'm actually struggling a lot. So our university offers all of these workshops and these webinars, and I take everything that I can, and then I try to go back to my department and I try to implement things that I've learned, and I'm talking to people that we're not all on the same plane, right? We're not speaking with the same language, the same foundation, the same understanding. It's very problematic.
I think a lot of it is self-reflection, being able to see yourself where you're at on this continuum, because it's a continuum of racism. And as a white female, though I have indigenous roots with my grandfather, a white female is what I identify as in society. I still am on that continuum of racism, and I have bias within me. And I think it's that ability to self-reflect and to say, how can we do better, that really helps. But I don't know how we can do that.
And I think that was a comment, we've been talking about this implicit bias. I don't know if anybody here has done any implicit bias training. I've did like a 2 or 4 hour workshop, and it's an interesting thing because I think that initial awareness is so important, but this is a daily thing that you have to consciously strive to improve every single day, because it's absolutely ingrained in us. And somebody that I've been working with, he's a white anti-racist, but he said as white people, the best that we can do is be a white anti-racist racist, because we're always going to be racist. Inherent in us.
I've even heard comments like unconscious bias we shouldn't be worried about because it is unconscious. I have heard comments even from enlightened senior colleagues that why should we be bothered about unconscious bias, because it's unconscious. Don't need to worry about it. And in terms of training, unconscious bias training to be mandatory, there has been attempt, and it has been considered that now fire safety training is enough. We don't need unconscious bias training.
More with respect, I think I don't know if somebody's initials JS is here, but JS Bambra is very. I have a lot of JS Bambra from if you're BAPU's chairman, he really disagree with the concept of unconscious bias within NHS, because you're giving an excuse for people to be to be what they is. So I used to disagree with him, but more and more I'm studying about it. Remember, I'm not an academic at all. I agree with him. There could be a thing called white privilege, which is unconscious bias, because you can't really go. Your white privilege is white privilege. That's a society. It's a society. This is other people who behave. So white privilege you can maybe consider as unconscious bias. Everything else is not unconscious. Right? So we give them an excuse in the NHS. This is an excuse of going, oh, it's an unconscious bias. I know that I don't drink, but I can still go to the pub and have a Coke. Right?
Yep.
So unconscious bias is giving them excuse. You can give the excuse of being a white privilege, but not unconscious bias.
However, I would actually, my personal preference is implicit bias, because it is actually not just bias against race. I think we need to be fighting against all kinds of prejudices based on this negative stereotype, negative bias. So it's not just racism, it's also about LGBTQ. It should be against Islamophobia, it should be anti-Semitism. We should be, all kinds of prejudices have to be protested against.
I think absolutely. And I know, like, on our last call, we were talking about that social identity wheel, right? And I think that there's all types of social identities, and it's not always just race, right? But if you're falling on that identity wheel that is against the grain of the norms, so if you're on that side where you are part of the norms, the more privileged you are, and the more that this is not at the forefront of your thinking, right? And this is influencing your behavior, and we tend to, enforce our norms on the rest of the world without even necessarily thinking about it. It's more implicit, and it's really we have to take accountability and responsibility for making this more conscious.
Exactly. That will, by the way, recently a tweet was made on that will, and it went viral incredibly. And strangely, I would say 70–80% of people commented against it with a wrong understanding of the proportionality. They thought all these things are equal. So therefore, they were saying that sort of just by not being short or poor, everything else I could be everything else, but not short. That makes me vulnerable. So I think the problem with the will is it needs to be made explicit that these are the items. They do not represent proportionality, and proportionality will be extremely difficult to attribute.
Yeah, that's an important point. That's like the visual on its own without the education surrounding it is a problem, especially for privileged people, which jump to these assumptions.
Can I just say that, you know, we want change to happen, but change won't happen if it doesn't affect the people that are in power. So I think Professor Laurie was talking about how you can go and have all this data, go into your department, want to change things, and nothing, you know, people aren't willing to change. Why would they be willing unless it affects them? And that is the real barrier that we have, that ideally, you know, just like the 60s dreams of Nirvana, we would like everything to be equal and fair for everybody, but we all house little biases and prejudice inside of us. That isn't the thing. This is a bigger thing that is about structural biases that are being placed in societies to their disadvantage. And it has something to do with politics as well, just as the gender politics come in. I think it's a really difficult subject, and you can't just go in, you know, you could produce data, as I said a number of times in the chat, with the rest data being available to us since 2015. No change happens unless it affects those who are in power as well.
See, Mike Walling, for every chairman there, Mike, if you are there, you could make a comment, please.
I just wanted to respond to the,
yeah, sure.
Yes, I believe, I agree with you holistically. We really need to have a systemic analysis of the issue that is in-depth, intersectional, that looks at the micro, the meso, and the macro components of this huge disease that we have in front of us. It's a disease, this racism, and it's systemic, and it's not going to go away with us just having few little talks and, you know, these sort of things. We have to tackle it with exes, with those who are in power, with those, you know, systems that need to be changed. And it's complex and it's not easy, but it must be done.
Yeah, can I just come in? I think Professor Rao said, Mala said basically is that we can do something in our sphere of influence. Let's start where we can start, because if we can't make a difference now, you know, after, you know, Black Lives Movement, after COVID-19, then we'll never make a difference. Now is the right political climate to do it. And you know, I can, but I talked to our trust chair, our chair of our trust, and he was going to come in, and he's agreed that we will have a BME board member for the trust, which will be selected by the BME network rather than being appointed. Right? So you can make differences where you're working, because even people don't want to, but the political climate is such that if you go with them now with a proposal which is reasonable, they will have to accept it even if they don't want it.
Absolutely right. It has happened in
now is the time to go in your locally wherever to make a change.
Exactly.
Because even if they don't want to do it, they will have to do it.
Yes, exactly, Ahmed. That is something which has happened in our hospital 2 weeks ago.
Well, I took this survey, I took it to him and I said, this is a survey where 18% people say that we have been verbally abused. It's okay. I'll give you a fund. You tell me what kind of person we need to appoint so that people of ethnic minorities or people who are difficult to speak up or don't want to speak up can go and speak up. You tell me what to do. So what I'm saying is that we can do something now because everyone is listening. Everyone is all ears, apart from our minorities minister, who seems to be black. That's why it doesn't mean that you need to be black. You need to, we don't need people. We need people who understand in the position to make a change. It doesn't need to be whatever color they are. They need to be there. That's one of the mistakes are that we are going to go do positive discrimination. I think that would be wrong.
No, but it's not.
That would be absolutely wrong.
Not just about the color. There is such a heterogeneity in that word BME, and I think that it's so difficult to actually, look. There is, there's so much heterogeneity that you can't just cater for. It's not about the color thing. There's so much more in it, and I'm glad for you that in your trust that your executive board, they have decided to appoint someone from a BME background. My trust, where I've been a consultant for over 25 years, it's shameful. Every year on year, it shows in the RES indicators that there is a all white, and you see it, and they are aware of it, and yet they cannot do anything about it. I don't understand it. You could show them the RES data, and from the way I speak, you can see I'm somebody who will, and I do challenge. But
it's a pleasure to see Reverend Mike Walling. I hope you will say something. It's lovely to see you.
Thank you very much indeed. I'm sorry I'm joking. I'm really supposed to be on break, but been following the conversation. Great. Thank you.
You have to unmute now.
Sorry. Again, thank you. I've followed this conversation and it's been quite fascinating and I am very grateful for it. I apologize for being rather croaky. One thing that's occurred to me in the course of this conversation is the fact there's been no mention of education, race awareness, education, training. And I say that I have some interest in this because, in my business, we're in the business of changing minds and attitudes. And for a while, I chaired a thing within my own church, which is the Methodist Church, pioneered by a remarkable black Methodist preacher, Sybil Phoenix, amazing lady, nearly 90 now. Methodist race awareness workshops. And we made it mandatory that anybody appointed within our church, at whatever level, whether it be the sort of our equivalent to the Archbishop of Canterbury, or a Sunday school teacher or a youth leader, they had to undergo race awareness training. And it consisted of folk from the White Highlands, because this was South London really, Methodists from the White Highlands listening to the experiences of their black brothers and sisters, mainly from the inner city. And they had to say, well, I will listen to you. You're not lying. You're my Methodist brother, clearly not lying. So I've got to listen to you. And I saw some real changes of heart and changes of mind during those amazing years. And it was really quite creative. Now, I know that this is still done, but there hasn't been much mention of that during this fascinating conversation this evening. We're talking about data, gathering of statistics, and all this sort of stuff, and addressing power, of course, which is what it's in the end all about. But it's about changing minds. How do you change minds? and attitudes. That's all I've got to say.
Mo, can I come in and say something?
Yeah, sure, sure.
Yes, hi everybody. Really enjoyed this evening, and we've had some fantastic speakers, and then some great conversations. I think that in the NHS, what I feel is that there is a lack of trust, and people are afraid to speak up because they feel that even if somebody tells them that you're okay to speak up, when they actually speak up, they get, into trouble. And people get, into all sorts of situations because somehow they get targeted, and therefore then they have to have a low profile, and then they cannot actually carry on with the good work, and they actually end up having to leave the trust. So I think it's about building up trust, and it's not something that can be built up in one day. And I know in East Kent people have left, and there are rumors about why people are leaving, and there is no actual decent story that as to why people have left. So then there are rumors and gossip. So what needs to happen is there needs to be transparency, trust, transparency, learning, and the desire, to actually improve. So unless there is desire to improve, things cannot get better. It's very, very important that we establish all these factors, and then maybe things can improve. At present, also there is no penalty for anybody who is a wrongdoer. Nothing at all. I've never seen a white man punished for being racist. Never, ever. And that is just wrong. You punish one person, you make him an example, everybody else will think 10 times before, behaving badly. So I think it's about the lack of, penalties. And I'm not saying I want people penalized, but I think it's important that, I actually see people demoted when they behave badly. So that's what is wrong, really. So I think we need to look at all these factors, and then perhaps maybe things will improve. I mean, Sash and Mo, I'm very happy. I've had a chat with Andrea on the chat bar today, and she said, come and work with us. And I'm very happy to come and work, But then I will be able to actually speak up at the trust meeting and actually say things that nobody else can say, because they can't touch me in that sense. And I can say all the things that you as employees, have to just swallow and shut up. Really, that's what it's all about. So I'm very happy to come and work with East Kent Hospitals and do what I can.
Thanks.
Okay, thank you, everybody. Thank you for your time.
For that offer. You are absolutely right. It will be dangerous for an employee to speak out. I'm sorry, Mike. That's the reality for 8,000 staff.
More, I humbly disagree, because I think in this day and age, if you know your rights, maybe it's difficult for people to be harmed. Because in my trust in March, I took my trust, I sent them that I'll take you to, if one of my colleagues have a sad outcome out of COVID infection, I will sue the trust for manslaughter. I'm the LNC chair, I'm a staff governor, and the trust had a risk assessment and gave all of us FFP3 masks in March last year. Right.
Yeah.
So there's law against, we don't need to be afraid to speak up.
No, but we just need to be careful, and I will pray for you, and I hope Reverend Mike will pray for you.
I also think a lot of people don't know how to speak up. And I think that goes back a little bit to what the Reverend was saying about the need for education. I did put a few links in the chat box about different education opportunities. I know IU has been doing a lot of education, and it's interesting because despite doing all of this stuff, I've been trying to have it change my behavior, right? I don't want to take a class and then my behavior doesn't change, right? I need to hold myself accountable to implementing what I've learned, but it's hard. And how much education is needed, and what is the education, and what is the mindset of the people that's taking the education? Because there's a bias in terms of the people that are offering, that do the education, and then are people that are being required, is it just checking a box, or how is that impacting behavior?
Don, you're absolutely right in what you say, But that's because, you see, for say you speak American English, people here will speak English. I'm from India and I'll speak Indian English. And so the way, the phrases that we use, the body language that we use, the way we come across, you know, one culture can find the other culture challenging and saying, oh, actually, he's being aggressive. No, I'm not being aggressive. I'm just an intense sort of guy, you know, that's what I am. But so what I'm saying is that try and understand what I'm trying to get across. Don't look at my face. Don't look at that like I look, you know, I got, you know, 3 eyes perhaps. Don't look at how I say. Don't look at my, you know, just look at what I'm trying to get across the point. And if we all do that and give people a lot of leeway, then I think we can, you know, overcome this problem.
If I could just make one comment, Mr. Sashi, I heard one person saying to an African colleague consultant that she looked so angry. And I had to tell those person, actually, that's her facial feature. She will look angry even when she is sleeping or dead, because that's what her facial feature is. She can't be angry when she's dead. But that is from a senior consultant colleague, senior doctor, who commented that that woman looked very angry. She was just talking normal. So I think I will revert to Mr. Sashi to say a few words and let everyone go for dinner.
Can I just quickly tell one thing or share something?
Yeah, sure.
Because I'm like very junior. I just started working in NHS two years ago, and I've been struggling and having problems. You know, when these kind of talks and discussions are there, I feel much comfortable and I feel like I can open up. But when I'm like in some meeting with the department and all, I feel like, you know, I'm not part. Like they don't want to involve me. They don't embrace me, I feel. And also, like, you know, standing up and knowing the rights, I did that and I have faced consequences. Like, you know, you have to leave that department because people won't like, because they are in a position, and when you raise your voice, it's like other people, when I had trouble with my CS and I said that, you know, there are unfounded evidence. Basically, I got into training and there was like a competency which I have to show as a prerequisite for my training. And the current CS, my clinical supervisor, she questioned me saying that I'm not competent enough, despite me saying it was a friendly chat. And I said that if I wasn't competent enough, I wouldn't be given training, and it's a prerequisite to show my competency, then only I get into training. But then it was unfounded evidence, but I had to struggle the whole rotation, just proving myself. And what the other colleague said, that, you know, she's a consultant, no one can harm her. And if you say, and nobody will listen to you, or there's no evidence, even though she was like known for bullying people, there was nothing done. She was left alone. But I was in tears. I said that, you know, I want fair assessment, and I want to, like, I don't want any other trainee to suffer like what I have been through. So after so much discussion, they said that, you know, the assessment on you stays as it is. We don't nullify what she said, but we will change your CS because she has requested it, not because, you know, I had problems, or, you know, the questions were raised. So these are, like, you know, what drives say and what you know, the things are in place is completely different. It's sad. It's very sad. And I had to, like, I used to dread going to department. I used to feel like, you know, oh, what will they say? Maybe because I'm different, appear different. I could not even understand why things been so hard or difficult for me. Is it because, like, you know, I dress in something like different, or is it because I'm from different country? It's really sad, but, like, you know, many people are afraid. I've spoken to many people and they say that, you know, there won't be any change, and it's like you will be in trouble rather than any changes. So this is, I don't know how to change and, you know, how to go about it.
Thank you for that. Thank you. Nitin, you want to comment on that?
Yes, yes. I was just going to say, Hajera, you are very, very brave. You know, you're very brave to speak up, you know. I'm now 61 years old, and I have only started speaking up in the last 5 years of my career, really. And it became so much, and it's so tough that you end up leaving the place, really. So what you're doing is very brave, but it does affect, you know, everything. It affects your career. It affects how people look at you, treat you. But things are getting better. You know, people are becoming aware of these situations now, and people will mistreat you less. So I would say just be careful. You know, there is something called a freedom to speak up guardian in your trust. There would be. So you should go and speak to them, and you know, they can be trusted people that you can actually, you know, they can be a shoulder that you can lean on. So I think that's the sort of person that you can go and talk to. Or you can speak to somebody at the BMA if you're a member of the BMA. You know, Anil Jain is very helpful. I can help. You know, Ahmed's there. You know, we're all there, and we can, you know, advise you, guide you, help you out in that sort of things. But hopefully you'll find perhaps some sort of senior figure who can be a guide for you, and you know, just somebody who listens to you, so you can, you know, weep your heart out in front of them without being judged in any way.
Yeah, Nitin, can I just add? Sorry, Hajira, what I would suggest is, yes, you need to speak up, but you need to do it in a proper way, especially if you're a junior, right? So what I was saying was, don't take it the wrong way. You just start speaking up, but there's always the right way to complain and go to the right person through a right channel, like Nitin said, or get the right help, right? So yes, you need to be very careful within the NHS. You do it, you must raise your voice, or you must want to get the right help. And if you want to raise your concerns, do it in the right way.
That's great advice.
Thank you.
So Jared, that you have support, okay?
Yes, please, Mr. Sashi, if you could conclude.
So we want to thank everyone for this incredible session. Thanks for your patience. It finished fairly late, but in some respects, it shows the passion that is behind these kind of meetings. I want to thank the international faculty. Honor to have you here. Want to thank all the speakers. The take-home message is resoundingly clear. We need more cross-specialty research. We need to back what we're saying with research. So these kind of meetings are very important. And I'm sure Karen and Mo and all of us are taking close notes and looking at what next we can look at in terms of research to back what we're talking about. In addition to that, the key buzzwords, I'm a cancer surgeon, and we talk about multimodal approach, we talk about heterogeneity. All of these things are important. So heterogeneity in what we're trying to understand is important, because you can have number of vulnerable issues packaged into one person. So we need to understand it. It's not a simple black and white. It is a lot deeper than that. Heterogeneity is getting bigger and bigger, and it's widespread. So we need to understand behavior. And I love Reverend Walling's statement about education. The multimodal approach that I'm talking about is we can't hit it with just one thing. So Don, I appreciate what you're saying about education. It's not the only thing, but it is important. You need to start with it. But it's not the only target. We need to come in with a whole bunch of stuff. Support is important. So all of these things we need to focus on. And Mo, I want to thank you for putting together this incredible meeting. Sorry you can't meet us here, but you look better on this. On that screen. I can see you clearly there. Okay. Normally when you're in here, I can't see you because I was looking somewhere else. So that's great. So Mo, when is the next meeting? Is it in May, June? We want to announce
around May, June, and around May, June.
Okay.
And we'll have more international speakers at that time as well, mainly from America.
Excellent. So thank you, everyone. It's an honor. See you.
Bye-bye. Thanks. Stay safe.
Everybody. Bye-bye.
Bye. Thanks, Mike.